Good morning and welcome to the first annual De Silva Center for EBSTEIN'S Anomaly, brought to you by UPMC Children's Hospital of Pittsburgh. My name is James Ferris and I am functioning as the technical support for today's meeting. If you have used Zoom before, you may have noticed today's webinar is a slightly different format. Only today's presenters are able to share their screens and webcam. If you have questions during a presentation, you can click on the Q&A button at the bottom of your screen and type it there. The presenters will answer all questions at the conclusion of each segment. If you have technical problems during today's webinar, you can send me a message via the chat function at the bottom of your screen. Thank you for attending today's conference.
Good morning. My name is Victor Morell. I'm the Chief of Pediatric Cardiac Surgery at Children's Hospital of Pittsburgh of UPMC. And I want to welcome you all to our first annual De Silva Center for EBSTEIN'S Anomaly Symposium. This is a long time coming. Jose Pedro de Silva and Luciana have been here for about 5 years. And we've been talking over these years about establishing a yearly symposium in which we can share our experiences with the common procedure and the management of EBSTEIN'S Anomaly with all of you. I am extremely happy to say that we have over 400 participants from over 40 countries. Pretty much every continent is represented. We are very excited, and I hope that this morning proves to be very educational for everybody. I'm gonna now introduce Dr. Jackie Kreutzer, who's the Chief of Pediatric Cardiology here at Children's Hospital of Pittsburgh, who will go over again some of the housekeeping issues and introduce our first presenter. Good morning.
Thank you very much, Victor, and thanks so much for all the attendees from all over the world. Welcome. And I wanted to, this is a special moment for us all together trying to elucidate specifics of this fascinating disease, EBSTEIN'S anomaly. I'm grateful to UPMC and for the support, and to Congenital Heart Academy for streaming our webinar, and for all the speakers and participants. I'm going to present today. We have as the guest honor in this conference as faculty, Professor Bob Anderson. As you know, renowned pathologist, cardiac morphologist, very, very well known to all of us. And I wanted to welcome him, and he will start our first presentation on embryology and anatomy of EBSTEIN'S anomaly.
Well, good morning to you, ladies and gentlemen. My name is Bob Anderson. It's a pleasure to be with you this morning. And indeed, it's a pleasure to be joining you again in Pittsburgh. I have strong connections with Pittsburgh. I've been coming through Children's Hospital now since 1979. So what I've been asked to talk to you today is Ebstein's malformation, specifically the development and the anatomy. But it's appropriate if I start by telling you just a few things about Wilhelm Ebstein. As you can see, he was born in 1836 in Prussia. And at that time, Prussia also owned East Prussia. And he went to university initially in Breslau, which is now in Poland. He continued his studies in Berlin, but he returned to Breslau to start his career as a physician. He wasn't there long because he made great strides, and already by 1874, he was sufficiently well recognized to be appointed as the professor of medicine at Göttingen, perhaps the leading medical university in Germany. And he stayed in Göttingen the remainder of his career. But what we are talking about today should perhaps be called Presche's malformation, because it was Josef Presche who came into the hospital in Breslau, where Ebstein was working, and attracted his attention to the lesion we now name in honor of Wilhelm. Joseph was 19 years old. He was complaining of shortness of breath, palpitations. He'd had them since he'd been a child. He was blue. His heart was big. It was full of murmurs. Sadly, he didn't last long in the hospital and died about a week after his admittance. And this is why we now remember Joseph Prescher. These are the drawings that were made by Dr. Weiss of the heart that was seen at the autopsy that was conducted by Wilhelm Epstein. Here you're looking at the inlet aspect of the abnormal heart. You see there's a small remnant of the septal leaflet, and there's a tongue of tissue that joins together the anterosuperior and the inferior leaflets. And the consequence of this is that the valvar orifice is looking into the outflow tract of the right ventricle. Here is the outlet view of the malformed valve, and now you see that remnant of the septal leaflet, and the anterosuperior leaflet has a linear attachment. And in consequence of this linear attachment, the valve closes in bifoliate fashion. And that is the feature I'm going to be emphasizing for you. So if we are to understand the abnormal anatomy that we're going to be looking at, we need to make comparisons with normal tricuspid valve, because that will permit us to understand the variations I'm going to emphasize. But as I intimated, we're going to start off by looking at what happens during development. And I've been learning a lot about development over the past 12 months or so, because I've had the privilege of working with Wout Lammers, Jill Hicks-Poors from the University of Maastricht. And Wout and Jill have made interactive PD files that show the development of the human heart throughout the period of embryonic development, which lasts from 4 to 8 weeks of gestation. And this is a reconstruction they've made of a human embryo at the end of embryonic development, what we call Carnegie stage 23, when the embryo is 8 weeks old. In yellow, you see the atrioventricular canal myocardium. By now, this has been sequestrated to form the vestibule of what will be the tricuspid valve. There you see the right ventricular aspect of the muscular ventricular septum, and to the top of the screen, you see the underside of the leaflets of the developing pulmonary root. By now, the proximal cushions that separate the outflow tract into the aortic and pulmonary channels have muscularized, and they've committed the aortic root to the left ventricle. But here is the focus of our attention. That is the developing tricuspid valve. And I hope you will immediately note that it has only 2 leaflets at this stage. We can confirm that by looking at serial sections, and this is a serial section through a data set from the Human Development Biology resource that is now available for study in the United Kingdom. It's a little younger than the embryo I showed you a moment ago, Carnegie stage 22. It's a 4-chamber section. But what we see there are the fused atrioventricular cushions that will form the membranous septum, but they will also delaminate to form the septal leaflet of the valve. But as yet, there's been no delamination. There is the lateral cushion, which will form the anterosuperior leaflet. I can now return to another data set from the Human Developmental Biology resource, and this time we can look at it in the same cutting plane as I showed you in that reconstruction that was made by Wout and Jill. So there you're looking into the right ventricle, and there you see the aortic root. So it's the equivalent of the oblique subcostal cut made by echocardiographers. And there at the level of the atrioventricular junction, you see the undelaminated septal leaflet, and there you see the line of union between the superior and the inferior atrioventricular cushions that have formed this leaflet. You can also see the anterosuperior leaflet. What I want to emphasize is the angle between the atrioventricular junction, which when we look at the heart attitudinally is vertical, and the level of the hinge of the anterosuperior leaflet. And you see it's rotated away from the atrioventricular junction at the inner heart curvature. And that now separates the inlet from the apical trabecular component of the ventricle. And as yet, there has been no delamination of the leaflets, so that the effective valvar orifice is between this inlet component and the apical component and is looking towards the infundibulum, just as it was in the heart of Joseph Pressure. So the key to development is the delamination of the leaflets that lift the valvar orifice back to the level of the atrioventricular junction. Now, if we look at the normal tricuspid valve, we can appreciate that. The normal valve does have 3 leaflets, and that is because with normal development from the stage we looked at in embryonic development, there is the formation of the 3rd leaflet, which is located inferiorly. We can see that in this rather nice virtual data set made of an adult by my good friend and colleague, Shunpei Mori. Shunpei made this whilst he was working in Kobe in Japan, but now he's working at the University of California in Los Angeles. And these virtual data sets show us anatomy as it should be seen in the context of the living heart. So there you see the anterosuperior leaflet, the septal leaflet, and now we see that 3rd leaflet of the valve that is formed subsequent to the end of embryonic development, and it is positioned inferiorly. It is not posterior, although that is still as it is often described. The key point now, with formation of that inferior leaflet, the valve will close in trifoliate fashion, and that, of course, is why we call it the tricuspid valve. So if we look at it in the same aspect as I showed you in the developing heart, this is one of the beautiful images made by Diane Spicer. Diane also started her career in Pittsburgh, and Diane is emphasizing when we photograph the heart in attitudinally appropriate fashion, the atrioventricular junction is vertical. And the union between the inlet and the apical trabecular component is angulated away from the inner heart curvature. And that permits us to understand what is going on when the valve is malformed. Now, time is not going to permit me to discuss with you any great detail the features of valvar dysplasia. I will briefly mention segmental combinations and associated malformations, but what I want to emphasize is the anatomy itself in the setting of EBSTEIN'S malformation, in the setting of concordant atrioventricular connections, because the key to the variation is the location of that valvar orifice. And this goes back to some work I did with Christian Schreiber. Christian's sadly no longer with us. He came and he worked with me at the end of the 20th century whilst I was still at the Brompton Hospital. And we looked at 23 examples of EBSTEIN'S malformation. And when we put in the location of that valvar orifice, as I've shown you, it is displaced away from the atrioventricular junction in rotational fashion. I know that echocardiographers talk about downward displacement, but when we put this displacement in the setting of the heart within the body, the rotation, it is a rotational displacement rather than a downward displacement. And it is the variation in that rotation that is the key to understanding. So this, in fact, is one of the hearts from the Pittsburgh archive. And I cut my teeth learning about EBSTEIN'S malformation in the archive at Pittsburgh Children's Hospital. So there you see the anterosuperior leaflet. And just as in the heart of Joseph Pressure, there is a tongue joins together the conjoined septal and inferior leaflets with that anterosuperior leaflet. And now you see beautifully in this specimen the rotational displacement of the conjoined septal and inferior leaflets away from the plane of the atrioventricular junction. And it is that rotational displacement that gives us this bifoliate configuration of the malformed valve. And we see that beautifully in this heart also, that is remarkably reminiscent of the drawing that Wilhelm Epstein made of the heart of Joseph Prescher. So there in this heart, you see how the valvar orifice, the keyhole, is looking into the infundibulum of the right ventricle. And it is closing in bifoliate fashion by consequence of the linear attachment of the anterosuperior leaflet. But the anterosuperior leaflet is not always attached in linear fashion. So in this example, which to me as a morphologist is less severe, we have focal attachment of the anterosuperior leaflet. You can see there the anterosuperior leaflet with a normal attachment between the medial papillary muscle, the anterosuperior papillary muscle. And there you see that the septal leaflet, the inferior leaflet in this particular heart are deficient. There is far less valvar tissue formed, and it would be much harder in this heart for the surgeon to make the cone of valvar tissue that is the essence of the procedure described by Dr. Da Silva. So we see, in fact, the potential to form the cone of valvar tissue much better when we have this linear attachment of the anterosuperior leaflet, and the keyhole is looking into the infundibulum of the right ventricle. And now we see the atrialized inlet component with that linear attachment of the anterosuperior leaflet, the connecting tongue with the inferior leaflet. And the task of the surgeon now is to do what the embryo was trying to do, to try to return that valvar orifice from the union between the atrialized inlet to the level of the atrioventricular junction. And so it is when there is this linear attachment of the anterosuperior leaflet that the surgeon will be best placed in creating the cone of leaflet tissue that is the essence of Dr. Da Silva's approach to surgical treatment. On occasion, however, we can have an imperforate Ebstein's malformation, and that is because the keyhole is closed. So the key to surgical variation is that distal attachment of the anterosuperior leaflet, and it is a spectrum of malformation. The focal attachment, when it may well be much harder for the surgeon to create that cone of leaflet tissue, hyphenated attachment to that linear attachment, which is, in my experience, the most usual surgical variation, remembering that on occasion the valve can be imperforate. A couple of other key surgical points to bear in mind. We find the atrioventricular node where we expect it to be. It's at the apex of the triangle of Koch, because the triangle of Koch itself will not have been distorted by the presence of Ebstein's malformation. We should also remember the right coronary artery, because of course the right coronary artery is within the right atrioventricular junction, which is going to be markedly dilated in the setting of florid Ebstein's malformation. So there's always the danger of kinking that right coronary artery when the surgeon seeks to reduce the size of that right orifice. Now, thus far, I've only spoken about Ebstein's malformation in the setting of concordant atrioventricular connections, but we all know that when we have congenitally corrected transposition, and when in usual atrial arrangement, tricuspid valve is left-sided, then in the majority of cases, left-sided tricuspid valve shows features that have much in common with Ebstein's malformation, not identical. So now we call this the Ebsteinoid variant. And very rarely, however, the mitral valve can show evidence of Ebstein's malformation. But then, in the setting of Ebstein's malformation, it is the mural leaflet that is displaced rather than the septal leaflet. Don't forget the associated malformations. In most instances, there will be an atrial septal defect. Much more rarely, there can be a ventricular septal defect or even an atrioventricular septal defect. Pulmonary stenosis is frequent. When we find pulmonary atresia in the setting of an intact ventricular septum, then again, Ebstein's malformation of the tricuspid valve is a frequent finding. And for the arrhythmologists, we must remember that because the malformation deforms the right atrioventricular junction, in many cases, we have Wolff-Parkinson-White syndrome. So if I summarize, the major point to bear in mind is that there is displacement of the septal and inferior leaflets, and that reflects the failure of delamination during development. But that displacement is rotational, although when seen in echocardiographic images, it seems to be downward. The consequence of the displacement, the valvar orifice, is a keyhole in florid cases, and it's looking into the infundibulum. It is at the junction between the atrialized inlet component and the functional right ventricle. What I hope I have emphasized is that as far as the surgeon is concerned, the major variation involves that distal attachment of the anterosuperior leaflet. And it's perhaps a paradox that when I see less well-formed cases with focal attachment, it might be harder for the surgeon in this instance to make the cone of leaflet tissue, but as I've emphasized, is the essence of the repair that was put forward and has revolutionized the treatment, the repair put forward by Dr. Da Silva. Remember, ebstenoid malformation is frequent in the setting of congenital corrected transposition, and don't forget those associated malformations, but the major take-home point, the lack of delamination of those septal and inferior leaflets has given rotational displacement of that valvar orifice that typically is a keyhole looking into the infundibulum of the right ventricle, just as it was in that heart of Joseph pressure seen by Dr. Ebstein so long ago. Thank you so much for permitting me to share my experience with you, and I'm looking forward to the remainder of this exciting seminar.
Thank you, Professor Anderson, for this wonderful presentation. Now we will follow with the video demonstration of heart specimens by Mr. William Devine. He is a retired curator of the Frank and Sherman and Carol Lennon Heart Museum, Department of Pathology at the Children's Hospital of Pittsburgh.
Hello, I'm Bill Devine, and I'd like to demonstrate to you hearts that have Ebstein's anomalies. I am a faculty member of UPMC Children's Hospital of Pittsburgh and also a faculty member of the University of Pittsburgh School of Medicine. I'd like to start by first looking at the normal heart. Since we're talking about Ebstein's anomaly of the tricuspid valve, we're going to look closely at the anatomy of the right side of the heart. So we're going to open up the right heart and first look at the right atrium. This is a right atrium because we have these pectinate muscles coming off the terminal crest all the way around towards the coronary sinus, the vestibule. That tells you this is a morphologic right atrium. Here's the oval fossa, coronary sinus, and the tendon of Dodaro is here coming down towards the central fibrous body. Here's the annulus of the tricuspid valve. This forms a triangle of Koch. Right here is also the area of the membranous septum. If we look on edge here, a little closer, we can see the atrial muscle here, ventricular muscle here, and we have fibrous adipose tissue with the right coronary artery here. And this fibrous adipose tissue actually extends, and you can see it in this heart, all around the junction. Now, the annulus of the tricuspid valve is not a fibrous cord, but is fibrous adipose tissue, and this is hinged along this region. And this hinge point and annulus are one and the same in the normal heart. If we look at this right ventricle, we can divide the ventricle into an inlet portion, apical portion, and outlet portion. And this is a right ventricle because you have these coarse tuberculations going up the septal surface. We have a tricuspid valve, and we have a muscular sleeve separating the tricuspid valve from the arterial valve, that is the pulmonary valve. This is the medial papillary muscle. When you have an EBSTEIN'S anomaly, what has happened is that part of the leaflets of the tricuspid valve fail to delaminate from the wall, and actually the hinge point of the valve is depressed within the ventricle. So when you have this failure to delaminate from the wall, the septal leaflets or other leaflets of the tricuspid valve, it turns into a rotational type of defect, pivoting around the site of the membranous septum or the central fibrous body. You pivot this way, and what happens is, if we look at this normal heart, you can see that the opening of the tricuspid valve is pointing towards the apex or the apical component of the right ventricle. But in EBSTEIN'S anomaly, it is rotated so that that orifice is now pointing out the pulmonary outflow tract. That is one of the characteristics of an EBSTEIN'S anomaly. And in doing so, sometimes we'll end up with a nice shelf of muscle here, reduced part of the apical component, and we have very thinning of the atrial and ventricular walls, calling atrialization of this right side of the heart. So the right atrium and part of the inlet of the right ventricle become atrialized and act like an atrium. This is a heart with an EBSTEIN'S anomaly, and we're looking at the right side of this heart, right atrium. Here is the annulus of the tricuspid valve of the septal leaflet. Here's the anterior superior leaflet, and here is part of the posterior leaflet. And we can see right here, if you go in closer, that this part of the septal leaflet here has not completely delaminated from the wall of the right ventricle, thus putting the orifice of the tricuspid valve within the ventricle, and you can see that it's rotating around the central fibrous body, around the area of the membranous septum in this fashion, and that the orifice of the tricuspid valve is now starting to face out the outlet of the right ventricle. And when you have this displacement or this delamination that did not occur, tend to get a shelf-like area here, and you start losing part of your apical component, and also you end up with atrialization or thinning of this part of the inlet of the right ventricle. This would be better showed in this larger specimen, which shows the natural history of an unrepaired EBSTEIN'S anomaly. It shows you the natural history of what happens when an EBSTEIN'S anomaly in some patient is not repaired. We open up, we see this very dilated, very large right side of the heart. The ventricular part of this ventricle is very thin, so it's atrialized. And you can see that this whole area of this heart is very dilated, will act like an atrium. You can see here nicely this shelf-like area with tethering of the cords. Here we have the septal leaflet. You can see this long sail-like anterior superior leaflet, and also the posterior leaflet is involved. You can see that the septal leaflet and posterior leaflets have this tongue of valvar tissue that comes up and connects the anterior superior leaflet with the posterior and septal leaflets. And you can see that the outlet now from this right ventricle is towards the pulmonary trunk, because the Epstein's anomaly has this rotational appearance. If we open the outlet, we can see that the outlet actually is also dilated. You can see the very thin wall of the outlet of the right ventricle. This is not usual finding, but when you have end-stage natural Epstein's anomaly, you can end up with this appearance. Here is the pulmonary valve here. If we close this up in this manner, we can see that now the outlet is pointing towards the pulmonary trunk and not towards the apical part of the right ventricle. Now, this specimen is shown even more detail. We're looking again now at a very large, unrepaired Epstein's anomaly, showing the natural history of this disease in this patient. We look in there, we can see this very dilated, thin-walled atrium and ventricle. And if we look down into here, we can see that the orifice of the tricuspid valve now points out to the pulmonary trunk and not into the apical part of the heart. If we turn this heart so that we're looking at the outflow tract of the right ventricle, you can see this bifolate abnormal part of the tricuspid valve that is pointing directly out the outflow tract of the right ventricle into the pulmonary artery. And essentially, the inlet and apical part in this heart have been atrialized. The surgeon can use part of this muscle, and it is muscle, to create the new position of the tricuspid valve at the level of the annulus. We look on this side, though, we see we have the valve, this part of the bifolate valve tethered to the heart, but if you look closely, it's very close, and you have to be cognizant of the right coronary artery. This smaller heart shows a very severe Epstein's anomaly. You can see that the septal leaflet is not delaminated. You can see that the anterior superior leaflet and actual part of the posterior leaflet are all sail-like. Here is your outlet. Remember, the defect in an Epstein's anomaly has a rotational effect for the orifice of the tricuspid valve, and it points out the pulmonary tract. But this heart has pulmonary atresia. So there's valvular atresia in this heart, and there is an association between the Epstein's anomaly and pulmonary valvular atresia.
Many thanks, Bill and Professor Anderson. Now we're going to proceed with our program. And next speaker is Dr. Lizabeth Lanford. Libby is the interim director of the Echo Lab, very talented imager with us. She's associate professor in pediatrics here. And she'll be talking about echocardiography, what we need to know.
Thank you. Good morning. I've been asked to describe the echocardiographic findings in Epstein's anomaly in 15 minutes. Obviously, the tricuspid valve is a very complex structure. I think most of us in the echocardiography world try to avoid describing it very carefully. In the last several years working with the De Silvas, I've learned a lot, and mostly have learned that there's more to learn. So in this 15 minutes, I thought I would take you through two cases with Epstein's anomaly that I thought were fairly informative for us. No disclosures. This first infant is an infant who had a prenatal diagnosis of Epstein's anomaly with significant tricuspid insufficiency. Their small local medical center said that they had no treatment to offer the infant post-birth. The family sought out the De Silvas and relocated to Pittsburgh, and the infant was delivered here. This is her newborn echo. As mentioned by Professor Anderson, the classic echo criteria is the inferior displacement of the septal leaflet. So looking at an apical 4-chamber view, you see left atrium, left ventricle, dilated right atrium, right ventricle, and here is the septal leaflet, which certainly is displaced inferiorly. I never really noticed before, but as we look, this leaflet here, which is probably a combination of the inferior and anterior leaflet, is fairly mobile, and there appears to be a reasonable RV anterior wall. When we add color, we see that this newborn had severe tricuspid valve insufficiency. The view that I like the most in infants and young children is the subcostal views, because you can actually get en-face views and fairly easily identify the 3 leaflets. I will say, as the valve gets abnormal, it becomes harder and harder to distinguish exactly which leaflet is which. So this is a subcostal 4-chamber view to orient. It's going to be head, feet, rightward and leftward. And we've actually tipped somewhat into the RV outflow tract because, as has been mentioned, the coaptation point of the tricuspid valve is tipped, rotated towards the RVOT. So this is a view that is very useful for that. And we can see the dilated right atrium. This portion here is the atrialized right ventricle. The coaptation point of your tricuspid valve here is rotated into the proximal right ventricular outflow tract. She actually has a fairly good RV apex that is part of the functional RV, a well-developed RV outflow tract. And you get a hint here that we see fairly often of sort of a dilated right ventricular outflow tract right below the pulmonary valve. And again, note that this tricuspid insufficiency is directed inferiorly. The peak TR gradient was 12 millimeters of mercury, so quite low for a newborn. We struggled with whether this patient had a patent pulmonary valve because her RV was only able to generate 12 millimeters of mercury, which would not be enough to open a pulmonary valve in a neonate. The question is it an abnormality of the RV myocardium, or is it that there's so much TR that the RV just cannot generate pressure? Surprisingly, there's a remarkably normal tricuspid flow Doppler inflow pattern across the tricuspid valve with E and A's. So at least we know we found the functioning tricuspid valve. So again, my favorite, the subcostal views. In infants and young children, you can get an en-face view of the tricuspid valve. It's a subcostal short axis view rotated into the plane of the tricuspid valve. So for orientation, it's again, head, feet, anterior, posterior, LV, mitral valve, septum. So here is your septal leaflet, and you can see this very redundant anterior leaflet, which really does not appear to have a lot of attachments to the right ventricular outflow tract. But then there's sort of a large chunk missing, right? There's no obvious inferior leaflet, and there is a very large gap here. Again, as you notice, this RV outflow tract is well contractile, somewhat dilated, and here there appear to be pulmonary valve leaflets. If we look at the color flow, this broad red jet in the MPA is ductal flow, supplying flow to the lungs, but we never see any forward or retrograde flow across the pulmonary valve. And again, we weren't sure whether this was functional or true pulmonary atresia. This infant went on to have a Starnes procedure done at 9 days of age. This consists of a fenestrated closure of the tricuspid valve, which is this patch sitting in the atrium. It still bothers me because as an echocardiography, tricuspid valve should be over here, but here's your mitral valve. This patch sits higher than the mitral valve. There was a right atrial reduction atrioplasty and a large atrial septectomy, a BT shunt. And again, intraoperatively, it was confirmed that the pulmonary valve was atretic. You see that the RV now is much smaller. You actually see, again, as I pointed out, that this child has fairly well-developed anterolateral RV wall. And the tricuspid valve leaflets are now all compressed in this small cavity, so you can no longer really assess the anatomy and function of these leaflets. So when we evaluate patients who've had EBSTEIN'S for further surgical interventions, I really like to look at the newborn echocardiogram to assess the tricuspid valve leaflet attachments, morphology, motion. There's a fenestration in that patch, so there is 2 flow across that right atrial patch. Again, surprisingly to me, there's a normal inflow pattern for an infant, an ENA wave, and there is tricuspid insufficiency. This infant had a peak TR gradient of 23 millimeters of mercury. We think that it is reassuring if the RV is able to generate a pressure for perhaps being able to recruit this right ventricle for future use rather than going down a single ventricle palliation. At 3 months of age, this infant had a Glenn and a surgical pulmonary valvotomy, and then at 17 months of age had a De Silva cone procedure associated with a pulmonary valve repair, ASD, fenestration closure, limited right atrial maze. The Glenn was left in place. As we now look at her postoperative images, you can see the 2 leaflets of the cone. You can see, as again, she has a fairly good RV anterior wall, and now she has a fairly large functional RV. When we look at the function of that tricuspid valve, I'm so amazed by these. We see some color flow disturbance, mosaic color, suggesting that she does have an element of tricuspid valve stenosis, but this little tiny jet is all of the tricuspid valve insufficiency that she has. So her mean tricuspid valve gradient is mild at 4.4 millimeters of mercury. She has trivial tricuspid insufficiency with a TR gradient that runs around 29 millimeters of mercury. She still is 1.5 physiology, so we left her Glenn. She was hospitalized for this cone procedure for approximately 1 week and had really no major postoperative complications. She is now about 3 years of age and clinically doing well. Her systemic saturation is 96% with a small bidirectional atrial level shunt on echo. Her tricuspid valve function has stayed stable. We re-echoed her a couple of weeks ago. She does have moderate RV dysfunction by echocardiogram, but you wouldn't know it based on her clinical course. Moving to another example this is an 18-year-old with Epstein's anomaly who had a BT shunt as a neonate. He has a patent pulmonary valve who just happened to move to the Pittsburgh area, independent of the De Silvas. At his first clinic visit in cardiology, his baseline stat was 81%, that dropped to 63% with walking down the hallway. So he had very poor transthoracic images, so we had a TE to assess what interventions we could offer. And so this is a transesophageal echo at 0 degrees, so similar to an apical 4-chamber view. Left atrium, left ventricle, right atrium, atrialized right ventricle. And again, the classic echo criteria is inferior displacement of the septal leaflet, but in this view, there is no septal leaflet. The mitral valve's here, your septal leaflet should be in here. So very abnormal septal leaflet, not at all visible. And what was most striking, and as I was preparing for this conference, I learned, it's probably well known, there is a very abnormal inferior leaflet here. You can barely see it with these small little attachments that is tethered. In addition, unlike the prior patient, I don't really get a sense of any true RV myocardium on the other side of that leaflet. We pulled the probe out a little bit to get into the left ventricular outflow tract, and all of a sudden we see that septal leaflet. It's been rotated into the outflow tract. And here is an anterior leaflet that appears to be moving fairly well. So to go looking for where the functional tricuspid valve, where the leaflets actually co-op, we've moved on to a short axis view. So this will be left atrium, right atrium, ASD. Here is your atrialized right ventricle. Here is that inferior leaflet with multiple attachments that doesn't really appear to move at all. And what was interesting about this one, teaching us the importance of communication between echo docs and the surgeons, is that when they opened this heart, all they saw was endocardium. They did not realize that there was a leaflet there. Dr. De Silva cut in and was able to find this plane, but the moral to me was that I need to make sure that the surgeon knows when I see a leaflet, because there are multiple attachments, and you can see that there is a plane that you can get into to free that leaflet up from the RV wall. And here we're starting to see the leaflets co-opt. With rotation of the TE probe, we can open up a hint of the pulmonary valve. That's this sort of white leaflets moving in and out here. Here is our coaptation point of the tricuspid valve. So this small RV outflow tract is the only functional part of the RV. This functional RV has a bulge, but the systolic function looks fairly good. Intraoperatively, they found that this area of the RV outflow tract had multiple areas of fatty tissue with absence of the myocardium. So unfortunately, this child has a fairly abnormal RV. And then this is just looking at 90 degrees to find the flow across that tricuspid valve. Again, I think that this is probably septal and a little bit of the anterior leaflet. And then when we look with color, we see moderate tricuspid insufficiency, again, directed inferiorly. I apologize for this image quality, but I wanted to show the abnormal attachments that you can see in that anterior leaflet. So this is a transgastric view by TE. So head, feet, left atrium, mitral valve, aortic valve, ventricular septum. And so this is focused on the right ventricular outflow tract. And so you see this very abnormal septal leaflet here. It's almost like a loop of tissue attached to the septum, which is now at the level of the aortic valve. And here is that anterior leaflet, which is mobile, but clearly has an attachment in the right ventricular outflow tract. The pulmonary valve would be up here. So again, this is our coaptation point that has moved all the way into the RV outflow tract, and the true functional RV is only this small area. Again, I was so sort of overwhelmed by this inferior leaflet here. This is the pre-cone picture that I've already shown you with the multiple attachments. This is actually post-cone, and you can see that the De Silvas were able to free up this inferior leaflet and to use it to form the cone. And if you look, I think there's actually little nubbins of tissue that I think are the remnants of all of those attachments to that leaflet. So for his surgical intervention, he underwent a De Silva cone repair, RV plication, valve closure of his atrial septal defect, RF ablation of his tricuspid valve annulus and cavo-tricuspid isthmus, and takedown of his BT shunt. And I was totally amazed by this result. So now we have what looks like the tricuspid valve with two leaflets, the cone. We can see low velocity flow. We don't see any turbulence in this inflow. We see that there are fenestrations in the cone to allow flow into the right ventricle. You can actually see this fenestration by 2D. And I think there's another fenestration which causes this red jet to swirl. There is no tricuspid valve insufficiency seen in that image. I went through the whole study, and the only insufficiency we found was this tiny fenestration here. And if you look very closely, there's a little blue jet and a little red jet. That little dot here of red flow was all the tricuspid valve insufficiency that was seen in the operating room. So I do a lot of echoes in the OR, and one of the most frustrating things for us is assessing valve insufficiency immediately post-op, because 2 to 3 days later, it's frequently very different. So I wanted to, bring to you the pictures of what he looked like 5 months afterwards. This is the last echo we have on him. Again, his tricuspid valve leaflets move well. Here is his color flow. Now we do see a little bit of turbulence. In the OR, his mean gradient across his tricuspid valve was 2. It's come up a little bit. But again, the only insufficiency that you are seeing is this tiny little blue jet. To find again the picture with the most TR, this was the most prominent tricuspid insufficiency I could find on his study. It was interpreted as trivial. He has a mean tricuspid valve gradient of 4 to 5, and a peak TR gradient of 16 millimeters of mercury, which was certainly better than his peak TR gradient, which was preoperatively was 10. His stats have gone from his pre-op of 81% to post-op of 91%. He is now only on aspirin. Thank you.
Thank you, Dr. Lanford, for this beautiful presentation. Now we will have interesting diagnostic images presented by Dr. Adam Christopher. He is an assistant professor of pediatrics at the University of Pittsburgh, director of cardiac MRI and CT program here at the Children's Hospital of Pittsburgh.
Good morning, and thank you for that introduction. Again, I'm the Director of Cardiac MRI and CT here at Children's Hospital of Pittsburgh, and as we've just seen from Dr. Lanford, echocardiography is our mainstay of evaluating the tricuspid valve, both preoperatively and postoperatively in Epstein anomaly. But I wanted to touch on some of the complementary advanced imaging modalities that we can use to further assess the tricuspid valve. So we'll just look at both pre and postoperative assessment of not only the valve, but also the right ventricle, focusing on the right ventricular function and volumes. And we'll look briefly at 3D echocardiography, what it has to offer, as well as cardiac CT, and then focus the bulk of this talk on cardiac MRI, as it really has become the ideal secondary modality to evaluate the tricuspid valve and right ventricle. So I want to start again just by touching on 3D echo, and for all the imagers in the audience, you know that it's readily available. We have these probes around, but often we defer to 2D echo. Clearly, there's no radiation involved, and if we're doing transthoracic 3D echo, there's no anesthesia involved, though TEE is a different story. But it provides detailed and dynamic imaging. So we really can get a feel for the depth and attachments of these valves and how they relate to the ventricle and the outflow tract. Obviously, 3D echo is dependent on the windows, even more so than 2D echo. And unfortunately, currently, 3D TEE is limited to those that can tolerate an adult TEE probe, so those over 20 kilograms. And again, I'm sure imagers would agree, there's a significant learning curve associated with 3D echo. And so especially in the heat of the moment in the OR, being able to not only orient yourself and optimize an image, but then orient the surgeon to what you're seeing in order to help their approach is certainly a skill to be worked on. But I just wanted to share a couple of relevant 3D echo images here. So again, you'll see TEE in a mid-esophageal view as well as a transgastric view, similar to what we just saw in Dr. Lanford's talk. But I wanted to add from that same patient, this is in a 10-year-old with EBSTEIN'S and severe tricuspid regurgitation. This is a surgeon's view, or close to it, looking down from the right atrium. The intraatrial septum is here on the left of the image. The aortic root is up here. And so you can appreciate, again, that apically displaced hinge point of the septal leaflet here along the interventricular septum. This sail-like aneroseptal leaflet, and we'll see a bit better from the inferior perspective some of those attachments of that leaflet. And then again, that somewhat deficient inferior leaflet or posterior leaflet down here. Turning that around and looking up from above, this is again a transgastric acquisition in the upper right here. I just want to focus your attention. So looking up from below, we have the left ventricle here on the right, and up from the right ventricular apex. Again, you can appreciate some of these attachments of the anterior septal leaflet to the free wall and the relationship of the valve to the right ventricular outflow tract and the pulmonary valve. This is now that same patient in the initial post-operative period following the De Silva cone procedure. You can see by standard mid-esophageal views, there's just trivial tricuspid regurgitation. And by, again, a transgastric view, looking up on F.A.C.C at the cone, you could appreciate some of the accessory tissue left on that anterior aspect of the valve, but otherwise excellent coaptation there. So then if we focus on these 3D echo images, again, from looking up from below, you can see some of that accessory tissue surrounding the cone. And again, relationship between the right ventricular outflow tract and that new valve. And then lastly, the surgical perspective from above, again, interventricular septum here, aortic root up here. So this is the septal aspect of the new cone and more of an anterior free wall aspect here. I just want to point out, even when the valve is coapting here in systole, you can see there's a bit of a groove left along that anteroseptal area. I think that's one of the beauties of the cone, is that there doesn't have to be a single plane of coaptation right up at the AV groove, but in fact that cone, can come together even just below the annulus here, and so we're still left with minimal, just trivial tricuspid regurgitation. So I think you'll agree there are certainly some advantages to intraoperative use of 3D echo, but I want to just touch on cardiac CT as well. So the pros here are clearly rapid acquisition and very high resolution, surpassing cardiac MR. I'll just pause this axial stack here as we come down into the large atrialized right ventricle and focus on, again, that anteroseptal leaflet here and how you can appreciate, especially as we come back up, some of the attachments to that anterior free wall. So really high resolution imaging of the valve. The cons obviously are the radiation involved with CT, though that has improved dramatically in recent years. And I'll put a caveat on this: limited dynamic imaging. So obviously with modern volume scanners, we're able to, at reasonable radiation doses, do a complete functional analysis and get dynamic imaging of this tricuspid valve. But we're still left with a lack of flow data by CT, and that's where MR really stands to give us the additional data we're looking for. So as I said, I want to now focus the back half of the talk on cardiac MRI and what it has to offer us in the setting of Epstein malformation. So the pros, and one of the reasons we refer almost every patient for preoperative cardiac MRI, is the quantitative ventriculography you get from it to assess not only the ventricular volume, but also the function of the functional right ventricle, as well as the dynamic and flow data that we'll review. Obviously, MRI is radiation free, but the real cons are the acquisition time, as well as the compliance. So in all of our younger and early school-aged patients, MRI will often require sedation and even intubation at times to get them through the scan and get adequate breath holds. So again, for the imagers in the audience, I'm sure you're familiar with this JCMR position statement. It's a really nice reference for cardiac MR protocols for a variety of congenital heart diseases, but notably as well for Epstein anomaly. I refer back to this frequently for standard protocols here. So I just want to touch on what we benefit, what we get out of ventriculography, tricuspid valve cine imaging, phase contrast imaging, as well as 3D imaging. We almost always perform either a contrast enhanced MRA or a 3D SSFP to be able to reformat this data. So just looking first at quantitative ventriculography. We standardly, for any cardiac MRI, will acquire a 4-chamber view. You can see in this patient with Epstein anomaly had previously had an AST closure device placed in the interatrial septum here. So there's some susceptibility artifact from that, but I'll focus your attention on, again, the function of the functional right ventricle down here, as well as the deviation of the interventricular septum. So standardly, we'll place a series of slices through this 4-chamber view and acquire a series of short axis slices to assess the ventricular volume and function. You can see here we've traced in red, occasionally you'll see the little outlines come through, the left ventricular endocardium. But in the setting of Epstein anomaly, it becomes very difficult to trace the functional right ventricle, again, because of the rotational variability of that annulus. And so it's standard, and we standardly acquire a stack of 4-chamber views in Epstein anomaly so that we can more accurately assess the functional right ventricle all the way up from the inferior surface of the heart to the right ventricular outflow tract and get nice, accurate volumes and functional assessment. I want to talk a bit more about focusing in on the tricuspid valve anatomy. And so we do that again from that 4-chamber view. If we place again a slice along the interventricular septum there to create this view, a 3-chamber view, much like the subcostal views Dr. Lanford was showing, as well as the anatomic specimens we saw from Dr. Anderson earlier this morning, you can appreciate again a right ventricular 3-chamber view with the right atrium, a portion of the atrialized right ventricle, and then you can appreciate the rotational abnormality of the plane of that tricuspid valve and its relation to the pulmonary valve up here. So then we can again place a plane perfectly parallel with the plane of the tricuspid valve, and then be able to assess it en face and see again the degree of coaptation or lack thereof, and again assess many of the attachments between that anteroseptal leaflet and the free wall. I want to briefly touch on phase contrast imaging or flow data that we can acquire by cardiac MR. So we'll frequently acquire an en face flow image of the tricuspid valve. And so you can see in red is the inflow in diastole here, and then, in blue is the inflow, and then in red is the tricuspid valve regurgitation. So this gives us an estimate, a rough estimate of the regurgitation fraction of the tricuspid valve. You can see in this setting, we got 45% regurgitation through this valve, consistent with severe tricuspid regurgitation. However, the challenge there is that the plane of that annulus is moving in and out of our single flow plane. And so it's often limited, and we'll end up using a comparison of the PA flow to the stroke volume of the functional right ventricle in order to calculate a more accurate tricuspid regurgitation fraction. I just want to make the point as well that 4D flow, which has come down the pike in the last few years, stands to dramatically improve our en face assessment of tricuspid regurgitation. So 4D flow is again phase contrast data in a 3-dimensional space, but with the added dimension of time throughout the cardiac cycle. And so you can see in this patient with Epstein anomaly, we're able to then track the annulus of the functional valve, that orifice, and get a more accurate tricuspid regurgitation fraction of 33% here. So then I just want to touch and give a few case examples of how cardiac MRI added to the echocardiographic picture. So this is a 2-year-old patient who, separate patient than the one Dr. Lanford showed earlier by echo, who presented as a neonate with severe Epstein anomaly and pulmonary atresia. She underwent the Starnes procedure as we had seen before, and you can see 2-fro flow through that fenestrated patch on cardiac MR. You can also see this very dynamic interventricular septum here. But she, as I said, initially underwent the Starnes procedure with placement of a BTT shunt, as well as subsequent bidirectional blend procedure. She then presented at 2 years of age with progressive desaturation, and so was referred for cardiac MR. Not only were we able to assess the flows through that fenestration, but also take a look at her branch pulmonary arteries. And using the flow data that we were just talking about, so you can see here the tricuspid or this patch en face. So you can see the 2-fro flow in red and blue here. You can see a hypoplastic RPA here under the aortic arch. And so we were able to compare the flows between the systemic and pulmonary bed and assess a significant collateral burden that was responsible for her desaturation. And so she was therefore referred for cardiac catheterization following this cardiac MR. And then I can't help but show a few MR post-operative images. Again, most of the cone patients are doing so well that we have few indications to send them for cardiac MR after the procedure. But I want to show you this image of a 20-year-old female who was a year status post her Silva cone procedure. Again, a similar view of that RV3 chamber view. We're a bit more posterior, but here's the right atrium, the right ventricle, and you can see the pulmonary valve up here. And here's this nicely anchored cone valve. See a slight element of prolapse here, but I want to appreciate the slowly improving function of the formerly atrialized right ventricle here. And then as we play a 4-chamber view here, you can see there's just trivial to mild tricuspid regurgitation through that cone. So then I want to conclude that obviously 2D echo is our mainstay of imaging, but that advanced imaging complements that. That 3D echo is useful, particularly in the perioperative period, and that cardiac CT has a growing but still limited utility. Cardiac MRI, however, is really important for surgical candidacy and preoperative planning. Thanks so much.
All right. Good morning, everyone. My name is Melita Villegas. I'm one of the cardiac surgeons here, and we've had an excellent first session on embryology and diagnosis of the cone procedure of Epstein's anomaly and cone. So we're going to open it up to discussion questions, and we have quite a few questions. So first one, and this might be for Dr. Anderson. So based on research I have done, there's no real cause of the malformation. Is that accurate? Are there any studies being done to determine what causes the defect?
None of which I am aware. I think the research is correct. We now have a feel as to why it takes place. I think the presentations we saw today showed beautifully that, as I pointed out in the developmental part to begin my talk, it's a failure of delamination of the leaflets. So we know that that's what's taking place. We don't know as yet why that should happen. I mean, there is minimal data to suggest that lithium exposure was able to cause EBSTEIN'S malformation, but I'm unaware of anything beyond that that would give us any clues.
Okay, the next question is the atrialization of the RV due to the lower pressure felt by that portion of the RV with resultant thinning, or is that region truly atrial histologically? That is this due to the hemodynamic or embryological origins?
Well, the inlet portion is for sure ventricular. It's ventricular myocardium, so it certainly isn't atrial myocardium. I'm not sure I'm the person to answer the other half of the question. All I can say is that it's ventricular myocardium. So it is atrialized in terms of the physiology rather than the anatomy.
Okay. This question is for Dr. Lanford. So the tricuspid regurgitation gradient in Epstein's anomaly and pulmonary atresia is high in what situations?
Can't actually remember ever seeing that, but I would assume it's when your Epstein's is competent, right? If your RV can generate a high pressure. I think it's the severe TR and the neonatal Epstein's that limits the RV pressure.
Yeah, so I would say that a higher TR, a higher RV pressure usually talks about a stronger muscle and stronger ventricle. So we like to see a higher TR gradient often because that reflects that makes us think that the ventricle is stronger and will end up having better function after the cone. That's probably what we would think. Any preoperative echocardiographic features that predict a successful repair or those that predict a failure of repair?
I have yet to see us say that there was an anatomy that we wouldn't try. I think that the second example I showed, I was very concerned that there would not be a good result, and Dr. De Silva was able to free up that leaflet. I think that that would be more of a surgical question. I'm always asked about attachments in the right ventricular outflow tract. Those are the common questions that I get, but I think I'll defer that one to the surgeons.
Oh, all right. So I will make some comments. So the most difficult ones were those really rotated to the RVOT, like that case that Dr. Lanford showed, and 8-year-old. In that case, the leaflets were very muscularized, so it was very difficult to find a valvular tissue, and there was not enough tissue to reconstruct the cone, so we used a piece of autologous pericardium to help it. And another type is the linear attachment, like one piece demonstrated by Dr. Anderson. There is a huge amount of valvular tissue, but we need to reposition the valve. We need to construct fenestrations to allow the flow to go inside the ventricle. And usually in that type of EBSTEIN'S, we have a hard dysfunction of the right ventricle in the postoperative period. And the focal attachment, the simpler one, has less tissue, but it's easier, the surgery and the management in the postoperative period, because the function usually is better.
Another question for Dr. Lanford. So for the 8-year-old with the BT shunt who had a cone procedure, did his functional capacity change post-op?
We don't know yet. He's just 5 months out, and with COVID, he's not really had much physical activity. I too am very interested to see what his physical capacity is going to be.
The oxygen levels.
Yes.
Have significantly improved.
Right. Well,
there was a kid that would go down to the 60s walking down the hall.
Correct. I think it was a beneficial surgery for him. I mean, I think the differential, I guess, would be, I don't remember the surgical discussion about whether you did this versus a Fontan, but now he has a functioning atrium, which gives him an atrial kick. He has a functioning right ventricular outflow tract. I'm not sure how much RV myocardium recovery he's going to have, because his RV myocardium is very abnormal. But I think having the atrial kick, the RV outflow tract kick, I guess, or if that's your, and no longer being shunt dependent should make his, should be an improvement.
And this question is for Dr. Christopher. In relation to RV function after cone procedure, which values do you consider normal? F.A.C.C, TAPSE, strain, or evaluation in MRI?
Right, so the F.A.C.C and TAPSE that's mentioned there are 2D echocardiographic assessments of the right ventricular function. I think this is where MRI is really valued for its complete volumetric assessment of the function. But I don't keep a separate standard for folks' status post cone. So if the RV volumetric ejection fraction is less than 45%, we'll call it abnormal at whatever degree it is. But I think it's important to keep the same criteria as you move along, and we'll often see slow but progressive improvement in that right ventricular systolic ejection fraction.
And this is more of a general function or question. So in regards to the LV function, are there differences before and after the cone surgery?
Can you repeat, please?
So as far as LV function is concerned, is there a difference before and after the cone?
Yes, as I said before, when there is a linear attachment and we remove the valve from that connection with the right ventricle wall. So usually we have some distension of that wall, and then we can have worse function after the cone. And also, like if you are measuring the ejection fraction, you will lose the regurgitation fraction, so you can have a lower ejection fraction, but still with a better output of the right ventricle.
So one of the questions was whether the cone changes the left ventricular function.
The left ventricular function. Yes, the stance procedure in the newborn increases the output because we have the decompression of the right ventricle. So usually we have the dysfunction of the left ventricle in the newborn or in the later presentation of the cone. If we have an older patient with left ventricular dysfunction, it would also a bad right ventricular dysfunction. So it's better to follow with the heart transplant than do the cone procedure. But in the younger patients, you can recover the function of the left ventricle with the cone.
I wanted to ask a question to Professor Anderson. I noticed that you said ebstenoid for when the Epstein, the tricuspid valve is ebstenoid in corrected transposition. And so I wonder if there's different and why you didn't call it Epstein's anomaly in that setting.
I've been taken to task for calling it Ebstein's malformation. As you say in the United States, if I was left for my druthers, I would call it Ebstein's malformation. The fundamental difference is that in my experience, although Ebstein's malformation is common in the setting of congenitally corrected transposition, it's very unusual to have thinning of the inlet component of the morphologically right ventricle, the feature that has been emphasized several times during this morning's presentation. So, for reasons that I don't know the answer to, typically that in congenitally corrected transposition, that inlet myocardium retains its thickness. I've seen a couple of cases where it has been thinned, as in florid arrangement of concordant atrioventricular connection, but it's because of that retention of the thickness of the inlet myocardium that I was pressed, and it's David Barron, who is now in Toronto. Previously, I worked with David in Birmingham, and David took me to task for calling it Ebstein's malformation and said I should call it the ebstenoid malformation. So I always do what my surgical colleagues tell me. So that's why I now call it the ebstenoid malformation. While I'm talking, can I pose a question to Luciana? Because I've grown up through the surgical treatment of Ebstein's malformation, and there's no question that the cone repair that you and your husband have produced has revolutionized the treatment. In the old days, when it was the Hardy repair, I was very good friends with Gordon Danielson, who was the major proponent of that. And at the Mayo Clinic then, there were still patients where they would opt for replacement of the tricuspid valve rather than opting for a Hardy repair. In your experience now, I note that you say you can use pericardium to make up if it is a deficient cone. Can I take it then that you would not now opt for tricuspid valve replacement?
Dr. Anderson, in our life, in our experience, we have almost 300 cones done now, and we replaced the valve only in 2 patients, and one was a Jehovah's Witness that was an older lady that refused blood transfusion. So to do a shorter procedure, we opted to replace that valve. And the other patient was not a real Epstein, was more a dysplasia, and he persistently have insufficiency and symptoms, so we opted to replace the valve. And Dr. Lanford showed, I think, the worst case scenario with the RVOT rotated tricuspid valve. And even in that case, Jose Pedro and with my help, we were able to reconstruct the valve, creating a very good cone, and the patient is doing really well. So nowadays, in our experience, I would say that is, unless it's an unperforated Epstein, like you showed, that we never found in our life. So I think that one would be the case where we would opt for another type of procedure.
All right, wonderful, Luciana, and thanks very much all the panelists. We're going to proceed with the continuation with our program. And the next subject here, we have Erin Colvin. She's supervisor for the advanced practice providers here at HBI in Children's Hospital. And Erin, welcome.
Good morning, everybody. Welcome to the conference. Next, we have a short video. Sorry, I'm gonna take my mask off. A short video outlining one of our families who went through the journey here at Children's Hospital Pittsburgh of UPMC and had their cone procedure. So please enjoy this short video.
6 years ago, I had our firstborn, Avery. We found out that she had Epstein's anomaly after I delivered. We had some complications and they took Avery right away to the NICU. After those 6 weeks, we were able to come home. Avery was stable and actually didn't require any oxygen. The next couple of years, it was letting her grow and develop and encouraging her to, you know, be herself and be as active as she could be. She was getting tired with walking and just having trouble keeping up with everybody. So we discussed with our cardiologist what the next steps were. He had mentioned the cone procedure, and after my husband and I started looking it up, we realized that the man who invented it was just a few hours away from us. From the moment we entered the door, we were just super impressed with the organization, the compassion. You know, after meeting with Dr. De Silva and his team, we felt very confident. So when she was 4 years old, about 2 years ago, she underwent open heart surgery and had the cone procedure done by Dr. De Silva. The surgery was very successful. You know, as soon as we saw her in the ICU, she was a color that we had never seen before. She was this beautiful pink, and I'll never forget that day. Dr. De Silva, you know, came and talked to us and saw Avery every day, and that really made us comfortable. She healed so impressively well. Children are just so resilient, and you know, we walked out of there after 10 days. She was walking around the hospital. We walked down to the pharmacy to get the meds. She was walking a further distance than she ever had before in the hospital. It was just amazing. Even as she continued to grow over the next 2 years, she still does things today that, you know, she was never able to do. We were able to walk the whole zoo a couple months ago. Previously to that, you know, we had to take a stroller everywhere we went. So we just love to see how she continues to grow and develop, and it's just so nice to see her being able to do the things that she wants to do. So we could not thank Dr. De Silva and his team enough for our outcome, and we wish everyone else the best of luck in their Epstein's journey, and thank you for letting us share ours.
Hi, my name is Avery. I'm 6 years old. I had a heart surgery. Now I can do stuff that I couldn't do before. I like to run now. I can walk all the way to the ice cream stand now. I now can tackle Everett. I liked how when I was at the hospital, my cousins could visit me, and I could play with them, but I had to sit on a chair or my bed. And now I don't have those tubes on me. So now I'm really good at running now since I already had my heart surgery. Thank you, Dr. Azelia, and thank you, team, for fixing my heart.
Well, that was quite a video. I have to say, it's the first time I see it myself, and it really is what this is all about, isn't it? It's about taking care of kids. It's about changing lives. And I have to say, in my lifetime as a cardiac surgeon doing pediatrics, there have been few procedures and treatments that we've created, instituted, that have dramatically changed care. And I have to say that Jose Pedro came up with this brilliant idea, and he instituted it in Brazil. I believe it was in the early 1990s when he came up with this and did his first case. I believe it was 1993. 2004, he published first paper on his new technique, which is obviously we call the cone, which we call it the Silva cone repair, because he's the guy who invented it and brought it forward. And it's been tremendous having him here in Pittsburgh. He's a tremendous human being. And that story is what this is all about. It's about improving lives. It doesn't matter where it is, but we can change kids' lives, and the cone procedure hopefully can and will help us do that. I am very happy to introduce Jose to the world. I'm sure you all know him. And he's going to go over the basic surgical technique of the cone procedure. Jose.
Thank you, Dr. Victor, for the kind invitation. And also thanks for the idea of founding the Silva Center for EBSTEIN'S Anomaly. I'm very happy to be here and to talk about the basics of the cone technique. EBSTEIN'S anomaly presents a large spectrum of morphological variation, which have incited the creation of many surgical repair techniques over the years. The most well-known technique and have helped a lot of patients in the past before the cone was the Danielson and Carpentier technique. Although they have some limitations, they're with very useful techniques. Here, this figure depicts the Danielson technique, which is a variation from the Hardy Hunter and then Hardy technique. And here you have anterior leaflet and lateralized portion of the right ventricle. He placed sutures in the annulus of the true annulus, the tracheal valve, and here mattress suture. Then once he tied them, he does transverse plication. And then they decrease the size of the annulus and get a monocuspal valve closing with the septum. This operation is good, but he needs to be a very mobile anterior leaflet to perform it, since it does not touch the leaflet themselves. Because of those limitations, in this series of 184 patients under the age of 12, actually the mean age of 7.1 years, he was able to repair the valve in only 28% of the patients and replace the valve in 63% of them. In this follow-up Kaplan-Meier curves, you can see that when you compare replacement versus repair with the Danielson technique, in adult, when we repair the valve, about 85% of them, after 15 years, I still didn't have any reoperation. But when you analyze the kids that have tracheal valve replacement at 15 years, only 40% of them were free of reoperation. Here, in the technique of Carpentier, he really detached the part of the anterior and the inferior technique, the inferior leaflet of the tracheal valve, and then he plicated the ventricle vertically now and put the valve in the right atrioventricular junction. And then he used the Carpentier ring to reinforce it. He operated in older patients, which are more risky, but he had 10% of mortality, hospital mortality, and in 10 years, mortality survival was 75%. So having those things in mind, we have developed an operation in 1993, intended to be a single strategy to approach all the wide variety of anatomical presentation of F.S.C.A. anomaly. The base of this operation is to mobilize all the leaflet tissues and then construct a valve in the format of a cone. And so this valve now does not close against the ventricular septum, but close leaflet to leaflet mechanism. Here is the cone concept. You see that we detach the leaflet, leaving only a small area of attachment near the apex of the heart. And then if necessary, we make some fenestration and then reposition the valve and the normal atrioventricular junction. So this is a picture showing the beginning of my experience, basically. So what I did, I detached, I had a case that I was planning to do a Denison technique, which I had learned in the Cleveland Clinic. And then when I was there, I saw that was impossible without touching the leaflet. So I detached the part of the anterior like Carpentier did, even though I didn't know the Carpentier technique. And I was planning to suture it in the septum. But then I saw that it was very close to the other side of the anterior leaflet. So I detached the septal aspect of the anterior leaflet, and then I rotate this and construct a cone. And the patient did well, even though she had to be reoperated 3 years after to perfect the repair. So in this case here, we have absent septal leaflet. But this didn't bother to construct the cone because I have enough tissues to ignore the septal leaflet. And here you can see a nice cone with 2 vertical sutures and a good result with the saline test, so no regurgitation. In this movie, I saw the cone, I showed the cone performance in the patient where I used the septal leaflet. Stop. So here you have the true annulus and the septal leaflets very displaced. So first we take down the anterior leaflet. Then we take the septal leaflet and make some fenestration on it. And then those are the fenestration. Then we suture the anterior leaflet to the septal leaflet, and then the posterior leaflet also to the septal leaflet. After we have the construction of that cone, we reduce the angle of the tragus valve and reposition it in the right position, taking care not to cause heart block. So this patient was studied 9 years after the operation. And here you can see the septal leaflet coapting perfectly with the anterior leaflet and no tracheal regurgitation or stenosis. This picture is to show that there is association of atrioventricular anomalous connections in about 50% of the patient. Actually, we can see tissues crossing the atrioventricular line, the annulus, in F.A.C.C. anomaly. That happened about 50% because of arrhythmia. And also, the AV node is a little bit more on the right in F.A.C.C. anomaly, according to that study. So in this case, we see here the tendon of Todaro, AV node around here, and there's a coronary sinus. So we tried to reposition the valve and follow this dotted line, a little supraannular, like you see here, to prevent heart block. And we do this whenever it's possible. Regarding the closure, in this PFO, we typically put one single stitch in the most posterior part of the septum, the primum septum, and then we bring it under. We making the valve mechanism for the foraminal valve. Here I'm showing the ablation of the abnormal conduction system, and also do ablation of the tricuspid caval isthmus to prevent arrhythmias. Here is the annulus, so I try to ablate all those abnormal tissue that could cause arrhythmia. It is oriented by our electrophysiologist team. This is a case long term after the operation, show a good coaptation of the tricuspid valve. And this graph shows that the first 54 patients who had preoperatively important tricuspid regurgitation, then was improved with the cone technique, and that result was maintained over the time. This is a case that was done before Carpentier technique repair. So it was working well at the beginning, but then the girl who was 5 years old and she had the operation, she had grown, and then the valve became more distant from the septum and acquired regurgitation, severe regurgitation. So we reoperate on this patient. So you see here that after the Carpentier repair, the valve, there's no valve in the septal area. And there's a little cleft here between the anterior and the inferior leaflet. So after the cone, you see now that in the septal area, there's tissues. And then when you put saline inside the saline solution inside the heart, you see the valve closing perfectly. I will show our results here at Children's Hospital Pittsburgh. We treated 36 patients and did 35 cone. So we did some innovations by doing the cone repair after the Starn procedure, and also addressing very complicated anatomical case. And we didn't have any mortality in this initial experience. And also we had an excellent quality team here to address those patients. And we tried to offer treatment to everyone. And some of them came and required the first treatment was ECMO. So other issues, other important information, that some of them had gland preoperatively. So basically, we tried to offer treatment for everyone, and we had replaced one valve 1 year after the operation. This Kaplan-Meier curves compare the patient that, the first 200 patients that we operate, the under 12 years old and older than 12 years. And there's a significant difference in results. So under 12 years of age, none of them died, either in the operation or later. As compared to the older patients. So we conclude that the cone procedure can be performed in nearly all anatomic variation of EBSTEIN'S anomaly with low risk. The tricuspid regurgitation repair is achieved in the cone technique is effective and durable in majority of the patients. The procedure restores the functional volume and may lead to reverse remodel of the heart in most patients. Our data suggests that the common procedure may result in better clinical outcome when performed at the young age. Thank you.
My name is Lee Beerman, pediatric electrophysiology at Children's Hospital. And I'm introducing our next speaker, Dr. Gaurav Arora, who is Associate Professor of Pediatrics, Associate Vice Chair of Pediatrics for Clinical Affairs and Ambulatory Care. But his true passion is electrophysiology. And it's been a real pleasure for me to work with him over the last 15 years as almost 15 years as Associate Director of Electrophysiology. Dr. Arora is a great clinician, mentor, teacher, and researcher. He is interested in Wolff-Parkinson-White and has made some important discoveries. And he's going to address the very challenging arrhythmia substrate in Ebstein's anomaly. I think he is. Let's see.
Thank you, Lee, and thank you, Victor, and thank you to the organizing committee for giving me the opportunity to speak with you today about arrhythmias and Ebstein's anomaly, diagnosis and management. Our objectives today will be to discuss the basic electrophysiologic anatomy in patients with Ebstein's, to understand the common arrhythmias that are associated with Ebstein's anomaly, understand preoperative management options and strategies, and discuss transcatheter and surgical ablation techniques. So in this Netter diagram, we have our usual hallmarks of the cardiac conduction system with the sinus node located in the superior right atrium, atrial conduction tracts coursing through the right atrium down to the inferior septal location in the triangle of Koch of the AV node, followed by the His bundle and infrahisian conduction system. And also take note of the cavo-tricuspid isthmus, the distance from the inferior vena cava to the tricuspid valve leaflet, which is often the substrate for macro-reentrant atrial flutter. In Ebstein's anomaly, the sinus node is in the usual location in the superior right atrium, but in many of these patients, atrial dilation increases the atrial conduction time. The AV node, by and large, is in the usual location in the triangle of Koch, as Dr. De Silva described in the prior talk. And infrahisian conduction is often delayed due to distal right ventricular abnormalities and conduction time. So the basic EKG findings in patients with Ebstein's are the presence of right atrial enlargement, as there is an increased vector from where the sinus node is anatomically located down through the atrium. There is typically a prolonged PR interval, but it's important to note this is related to increased intra-atrial conduction time and not truly related to underlying AV node disease or AV node dysfunction. There is typically RV conduction delay of some kind, either an incomplete right bundle branch block or right bundle branch block. And if right ventricular delay is not seen on the electrocardiogram, one should look really carefully whether this is a manifestation of pre-excitation, because it can be very subtle and not as obvious as other cases. The arrhythmias that are typically associated with Ebstein's include atrial arrhythmias, supraventricular tachycardia or SVT, Wolff-Parkinson-White or WPW syndrome, and ventricular tachycardia or VT. Atrial arrhythmias occur in 33 to 60% of patients with Ebstein's. Atrial tachycardia is typically related to atrial dilation and abnormal hemodynamics. Atrial flutter is a macro-reentrant arrhythmia, so a large reentrant circuit within the atrium, and often anatomically involves the cavo-tricuspid isthmus or CTI dependence. And atrial fibrillation can occur in these patients and is typically related to a progressive left atrial substrate.
This is an ECG with a typical appearance of atrial flutter. Notice on the rhythm strip at the bottom, the classic sawtooth appearance of the rapid atrial movement with variable AV conduction. This is an adolescent with atrial fibrillation. And again, notice the classic EKG hallmarks of an irregular rhythm with no obvious or discrete P waves in the baseline. Supraventricular tachycardia can occur in patients with EBSTEIN'S. The most common is accessory pathway tachycardia, or what is referred to as ORT, or orthodromic reciprocating tachycardia using accessory pathway. The pathway can conduct retrograde only, in which case we call it a concealed accessory pathway, or it can be manifest, which is what we call WPW, meaning that it conducts both antegrade so that we can see it on an EKG, and then the retrograde conduction across that pathway would be responsible for the narrow complex SVT, as I'll show you on the next slide. Patients can also have AV node reentry tachycardia. And so for patients who have supraventricular arrhythmias in EBSTEIN'S, one cannot assume that it is always related to a pathway. This is a schematic of SVT using an accessory pathway. Here's the sinus node, atrium, ventricles, AV node, His bundle, His Purkinje system. The typical tachycardia would go antegrade across the AV node, down the His Purkinje system into the ventricle. Here's the accessory pathway in the right lateral location, retrograde up this pathway, creating ORT. To contrast, SVT due to AV node reentry tachycardia would be here sinus node, AV node, His Purkinje. And the circuit in AV node reentry tachycardia is typically a circuit around the mouth of the AV node itself with passive activation of the atrium and the ventricle. And this is something we would distinguish in the EP lab at the time of EP study. WPW in EBSTEIN'S anomaly is a known common association. The WPW or antegrade accessory pathway occurs in 10 to 20% of patients with EBSTEIN'S anomaly. These patients are much more likely to have multiple accessory pathways, and therefore they are typically more difficult ablations than those ablations in patients with structurally normal hearts. And the accessory pathways are typically located at the usual atrioventricular annulus, so not necessarily at the site where the tricuspid valve is, but rather at the typical atrioventricular annulus. This is a sample ECG of a young patient with WPW. Notice the classic EKG findings of short PR, wide QRS, and delta wave. This ECG has late transition, suggesting a right-sided accessory pathway, as would be seen typically in patients with EBSTEIN'S. Ventricular tachycardia can certainly occur in patients with EBSTEIN'S, and this can be related to the underlying substrate itself. And a recent paper from Multi-Center Collaborative looked at the idea that the amount of atrialized right ventricle that is native has some implication as to the ventricular tachycardia substrate. It can be related to postoperative scar and something that must be kept in mind for the patients who are postoperative. And certainly this ventricular tachycardia contributes to sudden death risk, though there's no uniform agreed upon criteria for how we do sudden cardiac death risk assessment in this population, whether it be preoperative or postoperative. The substrates I think about as an electrophysiologist for sudden death risk include WPW, which can be associated with rapid antegrade conduction across the pathway during atrial arrhythmias and precipitate ventricular fibrillation. The possibility of AV block, thankfully with cone repair that is rare, but late AV block would be a risk. And then ventricular tachycardia, native VT or post-surgical scar VT. In the literature, one of the largest papers looking at sudden death risk was this experience published in 2018 from the Mayo Clinic. They looked at their cohort over 4 decades and looked at almost 1,000 patients, largely an adult population, 80% with severe EBSTEIN'S and about 20% with accessory pathways. And the risk factors they published were prior VT, which would certainly make sense that the presence of known ventricular tachycardia would contribute to sudden death. Clinical heart failure in these patients. I don't think that we would extrapolate this to our young patients who have symptomatic EBSTEIN'S as we have seen, because that's, I don't believe, the same pathophysiology. The presence of prior syncope, which we would all agree is a concern for the presence of a dangerous arrhythmia. The presence of pulmonary stenosis or the presence of polycythemia indicating chronic cyanosis. This is one of the few papers in the literature about what sudden death risk factors we should be following. But as I mentioned, I don't think there's uniform agreement in this population as how to risk stratify them for the purpose of placing a primary prophylaxis ICD. Preoperative electrophysiology study, or EPS, is certainly a discussion in these patients. There are groups that have published and advocate doing a preoperative EP study for all patients undergoing cone repair. But in speaking to people, I think many others, including us here at Children's Hospital of Pittsburgh of UPMC, perform preoperative EP study in select patients based on their arrhythmia history. So either a history of SVT, WPW, or VT, or symptoms suggestive of an arrhythmia, suspicious palpitations, or clinical syncope not otherwise explained. When doing ablations in WPW for these patients, accessory pathway ablation is certainly more difficult in the presence of Epstein. It is common for these patients to have multiple accessory pathways ranging from 6 to 36%. The electrograms in the EP study are often very fractionated in the atrium, which makes interpretation difficult. And the most common locations for these pathways are right posteroseptal, right posterior, and posterolateral, or as one would imagine, along the inferior margin where the largest amount of tricuspid valve abnormality is found. As I mentioned, accessory pathways are typically located at the usual annular location. So one strategy that has been employed is to consider locating the right coronary artery or the right AV groove. And this can be done either with an angiogram during the case, use of a coronary wire into the right coronary, or a small mapping catheter, such as a 2 or 3 French mapping catheter, to assist in annular location at that time. And recently, there's been an interest in using mapping with high-density catheters to facilitate accessory pathway location as well and help us understand where the true annular signals might be found. Surgical ablation absolutely is part of the discussion and should be considered in patients for whom it's appropriate. We should consider right atrial maze for patients who have known atrial tachycardia or macro-reentrant atrial flutter demonstrated. For patients with atrial arrhythmias and right atrial tachycardias, atrial debulking, I believe, plays an important role in helping to improve the hemodynamics and reduce the atrial stretch that leads to atrial tachycardia. You consider a left atrial maze for patients with documented atrial fibrillation. And surgical accessory pathway ablation, as Dr. De Silva showed in his last case, is very useful if transcatheter accessory pathway location is unsuccessful. Cabo tricuspid isthmus ablation. The CTI may be more difficult to anatomically access after surgery based on where the septal leaflet is placed back. And so one thing to discuss is whether if a linear probe allows for a fully transmural CTI ablation line, one could consider empiric CTI ablation line for all patients as part of a cone procedure to prevent future isthmus-dependent atrial flutter. I think this could be done safely with low risk of atrioventricular block given the CTI location and the ability to place that line lateral to the septum and far away from the AV node. And I think the key features would be the ability to deliver a fully transmural lesion with a linear probe, but having the CTI exposed prior to reinsertion of the leaflet is an advantage. In summary, arrhythmias are relatively common in patients with Ebstein's anomaly, and I think that arrhythmia assessment is an important part of preoperative strategy. Preoperative arrhythmia identification aids in pre-op EP study planning and ablation, surgical planning with maze or CTI line, and sudden death risk assessment. Consider a preoperative EP study for patients with known history of arrhythmias or symptoms suggestive of an arrhythmia. Transcatheter ablations for SVT substrates or hemodynamically stable VT substrates that could be mapped. And consider CTI ablation as a routine part of cone procedure, at least worth discussing. Thank you.
Well, as many of us know, not all Ebstein's anomalies are the same, and each patient is unique. And as it's been described by echo, MRI, CT, We have some relatively straightforward, what we would consider straightforward EBSTEIN'S anomalies, and we have certainly more complex ones. And I'll have to say that 5 years ago, before Pedro and Luciana joined us, I felt that most EBSTEIN'S anomaly were complex. And I always felt extremely frustrated with the outcome of the surgeries because it was inconsistent and somewhat difficult and not enjoyable procedures. And I will tell you, my world has changed with the cone procedure, which is reproducible. You usually end up with a significantly improved result. It's a game changer. Clearly, it's a lot easier to do a cone on a mild EBSTEIN'S anomaly. It's a different story to do it in an extremely complex one. But when you have a master like Jose or Luciana doing the operation, you see how it can be done. And like I always tell my junior surgeons, I said, you have to be a believer. And with the cone, you have to be a believer. It's doable, it can be done. And Jose is going to go over the more complex cone repairs that he's performed. Jose?
Victor, thank you again for your kind presentation. It has been a pleasure and an honor to join your great team of cardiac surgeons and cardiologists at the Heart Institute of Children's Hospital, Pittsburgh, UPMC. So the main surgical challenges in EBSTEIN anomaly repair are the severe tricuspid valve morphological malformation, tricuspid valve rotated, extremely rotated, say, to the right ventricular outflow tract, and severe damage to the right ventricle structure. And of course, a heart failure newborn with EBSTEIN anomaly, which Luciana is going to address. So here we have a lady who was 40 years old, and then she started having symptoms with EBSTEIN anomaly. The reason she had late symptoms is because she had a good structure of the right ventricle, and she had also she had severe tricuspid regurgitation. So when we operate on her, you can see that we construct the cone easily, and there is good support for this valve and for the right ventricle. In the right, you can see that the valve closes perfectly. And here the echo shows the good structure for the right ventricle with papillary muscles and everything, and a good function for the new valve. This patient also presents a relatively good structure for the right ventricle and for the tricuspid valve. Here's the anterior wall, the inferior wall, and this is the septal wall, the anterior leaflet, the inferior leaflet, and the septal leaflet. So we took down the anterior leaflet, the inferior leaflet, and then made that incision here, and also took down the septal leaflet. The septal leaflet at the end became the support for the inferior leaflet. And then we had an excellent result. But this patient was 90 years old and had a long history of cyanosis. So here you see the tricuspid valve closed very nicely, good inflow, no regurgitation, but the right ventricle doesn't work so well. So I think the expecting long-term with cyanotic patients is not good for the recovering RV. And here we have another patient who had global dysfunction of the heart, left ventricle dysfunction, right ventricle dysfunction, very dilated right ventricle, and had a gap of coaptation here between the anterior, maybe inferior, and septal leaflet. So because of this different behavior, we did a heart catheterization. As you see here, is a dysfunction right ventricle, very important regurgitation of the tracheal valve. And the reason for that is that she had a very dominant right coronary artery, which was stretched by the right side of the heart dilation, probably caused some degree of ischemia. So this girl didn't do well at the beginning. We had to place her on ECMO for 24 hours, but then she recovered nicely. Here you see the function of the right ventricle is very reasonable, good function for the tracheal valve. And here, there's a sign of good recovery of the right ventricle, which is the shunt, the atrial septum is from the left to the right, indicate a good function for the right ventricle. The chest X-ray preoperatively was very enlarged. The heart was very enlarged, and only 2 days after, the heart was much smaller, and the patient really did an excellent recovery and went home very early. So here is to show that it was this paper, this publication by Dr. Schreiber, unfortunately died young, and Dr. Robert Anderson showing the different situation of the abnormal annulus of the tracheal valve in EBSTEIN anomaly. Could be, the rotation could be minimal or could be very important in the valve opening toward the outflow tract of the right ventricle. So to construct a valve, to bring those tissues in this place, the valve opening toward the apex of the heart is more difficult when you have extreme rotation. This patient had, here you can see a gap of coarctation between the anterior and septal leaflet with the regurgitation. And then in this view of the outflow tract of the right ventricle, you can see that the anterior leaflet opens toward the pulmonary valve, very near the pulmonary valve, and there's a regurgitation here. So we have double orifice, one near the outflow tract of the right ventricle, in the outflow tract of the right ventricle, and the other one near the apex of the right ventricle. Importantly, this patient had a severe dilation of the outflow of the right ventricle. See here is round and is severe dysfunction. Here's the pulmonary artery. And this area should be different, so it's very dilated. We did the operation, we recovered the valve, but here the ventricle has some dysfunction. As you can see here in this cross-section of the cone, and there's some dysfunction of the heart early on, the early postoperative time, despite of a good function of the tracheal valve. Although this girl was young and she is doing very well clinically and improving the function. And this is a specimen that was shown by our colleague Devine today. We can see that the tracheal valve is like a membrane that is very tethered to the anterior wall and the inferior wall, and the septal leaflet is displaced. And here you can see the opening of the tracheal valve toward the outflow tract, which you see here. And the important thing is that the outflow tract in this patient who died when he was only 14 years old of age was very dilated and thin-walled. So here we have the same type of patient from the surgeon views. So this anterior wall is tethered to the tracheal valve and the inferior wall as well. And there's no septal leaflet because they are rotated. And you see just this little hole that is near the pulmonary valve and with some stenosis. So this patient was 6 years old. And this part of the tracheal valve was so tethered to the anterior wall that didn't let it dilate. So she had dilation only of the atrialized area of the ventricle. So we did the procedure, the common procedure, And here you see a membranous valve with just a little hole. And here we have a cross-section of the valve that closes very nicely. And the ventricle looks nice too, the RV. This because she was operated early on, probably. Now, this is another patient for the Dante Institute of Cardiology in Brazil that they have the opportunity to operate. This girl had also a severe dysfunction of the right ventricle, severe displacement of the tricus valve into the outflow tract of the right ventricle, as you see in this image here. So the valve is opening here, very near the pulmonary artery, the pulmonary valve. And here, the cardiac silhouette is dilated, and you see that in this MRI, that the anterior leaflet is very tethered to the right ventricle, and here the displacement toward the RV, outflow tract. So this is operation, so the valve is very abnormal. This is the inferior leaflet, and this is the opening toward the outflow tract. The septal leaflet is minimal. So here is where we have to construct the apex of that valve. So we start taking down the tissues very carefully to take only the leaflet and leaving the muscle to the myocardium, to the wall of the right ventricle. So here's a more normal leaflet, as part of the anterior leaflet. After we're done with this, there's a tendency to bulge the anterior DRV. Then we go to this anteroseptal aspect of the tricus valve and mobilize it, and then we have to cut those connections to the outflow tract of the right ventricle. Now we are taking down the septal leaflet, which is very abnormal, and we're going to use only to support parts of the anterior leaflet, which we have rotated from the outflow tract to this area here. Then we reposition, we decrease the size of the end, reposition the valve, do some fenestration, and then we look for holes like this one, for example, between the anterior and inferior leaflet. We have to close. And then we're going to work inside the right ventricle, getting some papillary muscles and some bridge and put together to improve the morphology of the right ventricle, hoping that will be useful for preventing dysfunction and ballooning of the right ventricle after this type of operation. So now we finish reposition the tricus valve, and we have excellent result at the end with very good coaptations of the leaflet. These are the echocardiographic results. You see that there's some prolapse of the valve, but the coaptation level is more internal, more distal, and the valve coapts very nicely. You see some muscle here that was taken with the leaflet that tend to thin over the years. And here's the 15 days after the operation with good hemodynamic and valve result. Some dysfunction of the right ventricle. This is another difficult case where the patient was 10 years old with a huge right ventricle and heart and right atrium. But here we have notes in this MRI that there's very thinning of the apical part of the valve, has some, and also in the outflow tract of the right ventricle. And here you see the left ventricle that is very small, compressed by the right ventricle. So in this operation, we remove some of this thin wall of the right ventricle, And so we reduced the size that way, and also in the outflow tract of the right ventricle. And we did a good construction of the trachea valve. And she responded well. So 10 days after the operation, the heart was already smaller, mostly because of the surgical maneuvers. But then after 4 years, the heart was almost normal size. And she was having some arrhythmias, atrial arrhythmias, and because of treatment, she required an atrial pacemaker. So this is the first drawing with the Dr. Epstein description of the disease. And I'll tell that probably this case would be repairable nowadays. So to summarize, an excellent trachea valve repair does not assure a good myocardial performance. Chronic cyanosis seems to be a factor to prevent RV reverse remodeling. Good mobility of the trachea valve anterior leaflet favor good postoperative right ventricle function. Severe rotation of the trachea valve into the RVOT, linear attachment of the trachea valve leaflet, and RVOT dilation seems to indicate a bad prognosis for the right ventricle post-repair performance. Early surgical repair in cyanotic EBSTEIN anomaly patients and in complex EBSTEIN anomaly anatomy seems to be beneficial. Thank you.
Thank you very much, Dr. Arora, Dr. Beerman, and Dr. De Silva. So we'll open up to questions again. First question for Dr. De Silva. When do you perform a Glenn shunt simultaneous with the cone procedure?
So the first question is about?
Is performing a Glenn simultaneous with the cone.
All right, okay. When normally in the EBSTEIN anomaly, we leave a type of pop-off defect in the septum, the atrial septal level, because very frequently the patient develops heart failure, dysfunction of the right, and the early postoperative care. When the right ventricle is so big in the beginning, and you know that the result of the operation will be not very good, there will be severe dysfunction. So in those cases, we plan to do the Glenn procedure at the operation. The reason for that is because it's the Glenn operation, you can unload the right ventricle and give more chance for its recovery. So that will be an indication. And also postoperatively, if the patient is not doing well, and they are, then this could be very helpful. The other thing that I will comment that in EBSTEIN anomaly, when they don't do well after the operation, you have to be very quick indicating ECMO. Because in the older time when we didn't have that resource, we delayed the indication, and then they developed irreversible shock. So if you want to recover the patient, you have to be very aggressive using ECMO if you have any doubt about the heart function and the patient develop low cardiac output.
Okay. Next question also for Dr. De Silva. So what do you consider the best weight or age to get the surgery?
Yeah, this is a tough question because it depends. If you want to do routinely, I think 3 to 5 years would be good to manage the patient. But if the patient is cyanotic, I will do it between 6 months and a year. If the patient has very complicated anatomy and you start dilating the outflow tract. Because this is something that can be misleading because the tissue are displaced around inside the ventricle, very attached to the anterior and sometimes to the inferior wall. So that area of the ventricle does not dilate because it's supported by those valves tissues, but they are very thin. And then when they start, so that if they have regurgitation, there's a tendency to dilate more the outflow tract of the right ventricle. So if that's starting to happen, you have to do the operation soon. So if I have severe cyanosis, then you have to do early on. I prefer to do between 6 months and 1 year. Now, if you have a more favorable anatomy, and then you don't hurry to do, but I prefer to do before they get to be teenagers, especially in the girls, because then they will grow. They have still the potential to grow, and that helps to improve the result of the cone operation. So it's kind of a complex decision, I would say, but if the patient is cyanotic, you have to do it as soon as possible, and also it has a complex anatomy. When you take down the leaflet, the heart will dilate. And if you have a younger patient that have the potential to grow, they will improve over time and have more chance of having normal function. I was really surprised when I saw studies of older patients of mine, and some of them with a perfect valve and perfect repair, but still the RV was not working so well with severe dysfunction, even though most of those patients didn't have any symptoms. But I am worried about the long term follow-up result on those patients.
And now an even tougher question. So how are your experiences of a cone repair after a Carpentier or a Danielson repair?
Well, I have had the experience only when 2 Carpentier repairs, but I have done cone repair even after prosthesis, after tricuspid valve replacement, as far as you have tissues down there. So if you have tissues, we still can repair. When you don't have enough tissue, then you can, I recommend nowadays, especially nowadays, to add some tissue, some pericardium. In younger patients, they use like flash pericardium. In a little older patient, we use growth aldehyde treated pericardium. So basically, it's not difficult to do. You can do it, especially after Carpentier, because half of the work is already done. So all depends how much tissue you have.
This is for Dr. Arora and Dr. Beerman. Why do a right atrial maze for aflutter, but left atrial maze for atrial fibrillation?
So what I would say in the preoperative patient is that atrial flutter is generally a right atrial abnormality. In the circuits, typically, they often in the preoperative patient will involve the CTI, as we discussed, but really we consider atrial flutter to largely be a right atrial substrate. Atrial fibrillation comes from pulmonary vein triggers in the left atrium, and so for atrial fibrillation in someone with a structurally normal heart, the standard transcatheter therapy is pulmonary vein isolation or PVI. And that analogy would extend to our congenital heart patients, where once the disease progresses and they get AF, then I think a left atrial maze or PVI is the therapy of choice for that substrate.
And if your ablation techniques don't work and the patient still has a high risk of sudden death related to VT or progression to possibly VF, would you consider ICD implantation?
Absolutely, yes. For patients who have known VT or VF, then absolutely an ICD is indicated. In this patient population, you'd have 3 choices. One would be placement of a standard transvenous ICD, but that means you have to go across that repaired valve. So that's a challenge we would navigate. The second is placement of an epicardial ICD system, which is off-label use of the current equipment that's out there, but certainly it's been reported and well done, and we've done it ourselves in this institution. And then a current newer technology in the last few years is the availability of the subcutaneous ICD for patients who are large enough that we can do that where we avoid the transvenous space. But the short answer to the question is yes, for patients who truly have ventricular arrhythmias, they absolutely would meet a class 1 indication for an ICD. I think the challenge, as I alluded to in my talk, is simply how do we identify those patients who might be at risk for ventricular arrhythmias? It remains a challenge for all of us to pick those patients correctly.
And then Dr. De Silva, do you always plicate the atrialized right ventricle? Dr. Del Nido once said he believed the plication can cause post-op cardiac arrhythmias.
Well, this is interesting to think rationally about that. If you need to placate too much, I normally placate small areas and on the thin wall, and with only endocardial suture. But when you see that you have patients, big atrium, you have a possibility of arrhythmia, you have to try to isolate that area electrically. Otherwise, you cannot come back to it. And the other issue that you have to be careful is about causing ischemia in that area, because the ischemia can be a cause for arrhythmia in the future. So you have to be very careful about that exclusion. Now, when you have especially small patients, normally I don't do plication like, the classical plication. What I do, I put sutures, isolated sutures. Then you can have access to treat arrhythmia. And also in young patients, they can develop myocardium in that area as it grows. So I don't always plicate classically, but always put sutures to decrease the area of the RV functional shunt chamber after the coma.
Should all patients have a pre-op EP study, or is there a minimal age for this in this group?
Yeah, I don't think that there's a minimal age. I think we generally do any indication of arrhythmias, whether it's symptoms, certainly the presence of WPW, I think is an indication for it. If a child does not have any arrhythmias, symptoms suggesting that, or any abnormalities on the EKG other than a right bundle branch block, I don't think we would do it for that. But if there's any indication, there's no age limitation to it.
Dr. De Silva, for adults with Epstein's, are there any criteria you would use to not offer the cone?
Okay, well, I always use the cone. So in my view, there is no criteria. But I would say if you have a very bad anatomy and that you have to put more tissues in the valve to construct the cone, it'll be very complicated. I think in patients that's over 30 or 40 years of age, you can plan for a replacement. But I haven't had the opportunity to do this, except in a lady that she asked to do replacement to make the operation shorter, as Dr. Luciana has mentioned.
Let's see. How do you think a 40-year-old Epstein's with severe anatomic abnormality, including marked valve displacement into the RVOT and small LV, but only mild to moderate TR and no right to left shunt, and doing well?
I didn't get that.
So in a patient that's 40 years old with Epstein's and has a severe anatomic abnormality with marked valve displacement, but only mild to moderate TR and no right to left shunting, would you offer a cone, or do you think that that's the right option?
Yeah, this is an excellent question. Yeah, this you have to do the stress test, you have to follow very well, but might not be a candidate for surgery. Maybe you can go on with a medical treatment. But normally you have to do the operation because it's very rare to see a patient with typical F.A.C.C. anomaly over the year 70. I saw only one case, and the patient had a problem in the left ventricle as well. So the only thing we could do was medical treatment.
So we're going to close the discussion for now. Don't worry, a lot of your questions will be answered. If they're not answered live, we will get to your answers eventually. And next up, we have Erin Colvin, most likely with another inspiring story for us.
Hi, everybody. As we prepare for our next group of talks on fetal and neonatal Epstein's, I want you guys to enjoy this short video, Kasyn Smith and her family and their journey through their neonatal Epstein's treatment.
Hi, this is Kasyn and my name's Michaela. We found out that Kasyn had Epstein's at her 20-week gestational scan. After we heard from the children's doctors that they didn't have much that they could do. It's pretty hard to hear when they just kind of tell us that they'll keep her comfortable when she's born. My sister is actually the one who found Dr. De Silva and read about him and saw that he created the cone procedure and that he specializes in Epstein's. We were relieved to see that somebody knows something about what she has. When they got back to us, Dr. De Silva actually called us and said, I can fix her. And when he said that, we packed our bags and we moved across the country to Pittsburgh. We moved 24 hours away from our hometown 2 weeks before Kasyn was born. It was a rough journey to move when you're about to give birth to in a new city. It was chaotic for a long time. Once we were there, we felt a sense of relief. Kasyn was born. She was very sick in the beginning. It was a rough time for a while, but we were just so blessed to be able to find a team that could do something and intervene and that could save her life. We were just so blessed that we were able to find Pittsburgh and the whole UPMC cardiac team, and it's just amazing what they can do. And we're just so relieved and happy that they're trying to spread more info out there to other people. It's a really great thing, and we're very happy. Kasyn is just a wild woman now. You would never ever expect that she was ever so sick in the beginning. It's amazing. We're so blessed, and we love all the whole team that helped us get to where we are today. Can you say, we're thankful?
All right. So the Heart Institute at UPMC Children's Hospital of Pittsburgh wants to thank the Congenital Heart Academy for their collaboration with today's events. With their help, we have registered participants from all over the globe. Following here is just a brief video about the Congenital Heart Academy and what they do. And following this, we'll have just a 5-minute intermission.
Hi everybody, welcome to Congenital Heart Academy. I'm Dr. Grace Monlewan from Sidra Medicine, Qatar, and I'm glad to give you a quick overview about us. We'd like to thank UPMC Children's Hospital of Pittsburgh for the opportunity to support and broadcast the Silva Center for F.A.C.C. Anomaly Symposium. The Congenital Heart Academy was founded by Dr. Gil Vernovsky from Children's National, Washington, D.C., and Dr. Sasha Gatti from Bambino Gesù in Italy. Dr. Sasha and myself are the co-chairs. We have the great support of more than 60 delegates from all around the world. Congenital Heart Academy is a web-based educational platform. dedicated to worldwide healthcare providers involved with congenital heart diseases, sharing high-quality scientific knowledge and experience in a spirit of collaboration and union among the multidisciplinary team all around the world engaged in the care of patients with congenital or acquired heart defects from the fetal life through adulthood. We aim to reach every member of the multidisciplinary team worldwide, continuously delivering high-level education, ultimately helping to improve team collaboration and patient care. Since the pandemic began, the Congenital Heart Academy has put on more than 90 free webinars with 16,000 unique participants and 125 countries represented. More than 100 outstanding speakers have shared their knowledge and expertise. We've collaborated with several societies, including Pediatric Cardiac Intensive Care Society, Congenital Cardiac Anesthesia Society, the Society of Pediatric Cardiology Training Program Directors, Saudi Heart Association, and CNOC, Fetal Heart Gulf Group, and the Caspian Heart Foundation. 8 webinars have been in Italian and 2 in Spanish. In addition to the webinars, we have several series, including Dr. Robert Anderson's Morphological Series, where we discuss one cardiac disease each Friday, Dr. Norman Silverman's Correlation of Echo Images and Morphology once a month, Dr. Mary Cohen Amazing Echo Series, and Fetal Cardiology Series. Dr. Giovanovsky has his own series as well, debating all hot topics in pediatric cardiac intensive care and much more. In addition, Congenital Heart Academy is a collaborator of the 8th World Congress of Pediatric Cardiology and Cardiac Surgery, planning to showcase the content created for the 2023 World Congress in a virtual fashion. All content from Congenital Heart Academy is free and allows participants to join on the Zoom platform interacting with the faculty on the Q&A chat box, polls, etc., and is broadcasted live on YouTube. The Congenital Heart Academy YouTube channel keeps all talks free for watching later as well. Please follow us on social media and subscribe to our YouTube channel. Invite your team and join us on our future meetings. Thank you very much for this opportunity to share with you more about Congenital Heart Academy.
Good morning. I'm Dr. Justin Ye, the Chief of Cardiac Intensive Care here at Children's Hospital Pittsburgh. I'd just like to extend a thanks again to the Congenital Heart Academy for their assistance with this symposium today. And certainly we'd like all of us as presenters to extend our thanks to the families who have shared their stories with us this morning. They certainly inspire us to push the science of the field forward and to give us the courage to have the belief, as Dr. Morell alluded to earlier, to face some of the dire circumstances we see with some of our patients when they're at their most critical point. In this section today, we'll be talking about the transition from fetal care to care in the cardiac ICU and surgical management of neonates with Epstein's anomaly. And it is now my pleasure to introduce Dr. Jennifer Johnson as our next speaker. She's an assistant professor of pediatrics in the Division of Pediatric Cardiology here at the University of Pittsburgh and Children's Hospital of Pittsburgh. She is the director of perinatal cardiology, and she will be discussing fetal diagnosis, gestational management, and childbirth planning.
Thank you very much for that introduction. Thank you to the organizers, and thank you to Luciana and Jose for allowing me to do this talk today. So we are going to discuss the fetal diagnosis and management and delivery planning of patients with Epstein's anomaly. As we've been talking about, Epstein's is a rare congenital anomaly and is seen in about 0.5% of all congenital heart disease lesions. It has a broad morphological spectrum and is made up of three main characteristics that we've been discussing. The nice part about this is that due to the insufficiency of the tricuspid valve, the RA and the tricuspid valve annulus is dilated, so these patients are easily picked up and identified by OB ultrasound done at about 18-20 weeks of gestation. So we get to see a lot of these patients prenatally, which has been great. So why is fetal diagnosis of Epstein's anomaly important? Well, as infants with Epstein's anomaly remains one of the most difficult congenital heart diseases to manage postnatally. Fetuses with severe tricuspid valve insufficiency are at risk for cardiomegaly, high drops, arrhythmias, and even fetal demise. In the 2015 multi-center study by Freud et al., the perinatal mortality for this cohort was up to 45%, which is significantly higher than other lesions in the current era. So research has been focused on trying to determine the fetal echocardiogram characteristics that put these patients at greatest risk for poor outcome. This venture has been difficult since it's been shown that the hemodynamic state of a fetus with Epstein's anomaly can evolve over pregnancy. In the study done by Turney et al. In 2017, fetuses with favorable hemodynamics early in pregnancy often became unfavorable hemodynamics by third trimester. So making the surveillance of these patients very challenging for fetal cardiologists. So the identification of poor outcome, what do fetal cardiologists look for? What are our sort of triggers? So in the study in 2015, they showed that diagnosis of fetal Epstein's anomaly before 32 weeks of gestation was a risk for poor outcome. They thought this was due to more severe disease being diagnosed by OB ultrasounds earlier in pregnancy. And in both multi-center studies, they showed that dilation of the tricuspid valve annulus showing an increased Z-score was associated with poor Epstein's outcome. The thoughts behind this is that these findings of tricuspid valve dilation correlate to the degree of the amount of tricuspid valve insufficiency, right atrial enlargement, and overall cardiomegaly. The reason why right-sided dilation is important is because it can lead to inadequate systemic cardiac output in two ways. So the overall compression of the left ventricle leading to decreased systemic output. And then it's also been shown that the severe dilation of the right atrium causes distortion of the PFO, therefore affecting and altering the right to left shunting across the PFO and decreasing the left ventricular preload. Another major marker that I think most people look for, and we're always hunting for, is pulmonary valve insufficiency, because it's concerning for the ability to set up for a circular shunt. In the 2017 multi-center study, they showed that pulmonary valve insufficiency was the most powerful indicator for poor outcome for these patients. Other markers of fetal distress, pericardial effusions, and then sort of looking, I think a lot of papers are now looking at tricuspid valve insufficiency velocity, sort of as a surrogate to right ventricular function. And those are also things that we like to trend and look for. So what are the things that we are evaluating in fetal cardiology for these patients that come to us with Ebstein's anomaly? Well, we obviously look at the tricuspid valve, the anatomy, the annulus diameter, what is the Z-score, looking at the severity of regurgitation. Also, the peak regurgitation gradient is also helpful for us when dealing with planning. Pulmonary valve, what is the annulus diameter, what is the Z-score? Is there antegrade flow through the pulmonary valve? Is there now pulmonary valve atresia? And then also very significantly, pulmonary valve insufficiency. Is there any concern for pulmonary valve insufficiency? Ductus arteriosus, is there antegrade or retrograde flow? What are the ventricles doing? Right ventricle, left ventricle, width, length, Z-scores, what is the systolic function? Cardiothoracic area ratios, the evidence of high drops, and cardiovascular profile scores. So what we look at is we look at each individual patient. We try to determine the severity of the Ebstein's anomaly and then their risk factors for poor outcome. And after looking at that, we sort of determine what our fetal surveillance is. For patients that are doing well, no pulmonary atresia, no pulmonary valve insufficiency, those patients might be seen every 4 weeks. But any patient who starts developing new onset pulmonary atresia or any pulmonary valve insufficiency, we tend to see those patients more often at 1 to 2 weeks. So how we sort of divide up our patients and try to determine delivery planning. So as we've talked about, the severity of Ebstein's can change throughout pregnancy. So this is a multidisciplinary team decision. So in our department, we talk with pediatric cardiology, cardiac ICU, NICU, maternal fetal medicine, cardiac surgery. And for our department, the transport team is also very important. Our delivery hospital is 2 miles away from the children's hospital, so they are also taken in consideration when delivering these high-risk patients. So for us, we mostly deliver these patients in the tertiary care center. We sort of divide them into 3 groups and sort of look at based on their pulmonary valve flow. So group 1 are those patients with moderate to severe tricuspid valve insufficiency, and they have antegrade flow through their pulmonary valve. And the tricuspid valve insufficiency peak systolic gradient is greater than 50% of gestational age. Those patients usually are able to be supported by oxygen if they have low saturations after delivery. Group 2 is that group of patients with pulmonary atresia who've had pulmonary atresia throughout their pregnancy, and they have no evidence of pulmonary valve insufficiency. These patients, usually there's, for at least transport, we put them on prostaglandins for the transport from the women's hospital to children's hospital. And then group 3, that's our fun and interesting group that always keeps me on my toes. So that is the group with pulmonary atresia and pulmonary valve insufficiency. And we sort of look at those all together and sort of determine where best these patients can deliver. Right now, we're looking at those patients with RV systolic pressures greater than 50% and pulmonary valve insufficiency, hoping that these are the patients that would have the best chance of the pulmonary valve opening. And these are patients that we are not putting on prostaglandins for transportation in hopes not to worsen a circular shunt. And then there's those patients with the lower RV systolic pressures. Those patients, we have prostaglandins on standby for the delivery just in case. Oxygen is not something, if we need a little bit more than oxygen. Also, we have epinephrine ready for these patients because sometimes the left ventricular function is poor. There's also those fetuses with concern for significant hemodynamic compromise due to their circular shunt in utero. These patients can be considered for non-steroidal anti-inflammatory medications. We will not review this type of patient in today's discussion. So we'll go over a couple cases that we've had. Case 1 is a patient of mine who had a normal second trimester OB ultrasound and then moved to the Pennsylvania area. They established care with a local OB office, which showed a dilated right atrium and interuterine growth restriction. A fetal echocardiogram was performed at 36 weeks of gestation, which showed severe tricuspid valve insufficiency, a tricuspid annulus, upper limits of normal, a CTA ratio of 0.4, so cardiomegaly, RA dilation, and there's antegrade flow across the pulmonary valve. And the RV systolic pressure was 30 at 36 weeks, so a nice RV pressure. So here, as you can see in this image, the right atrium is dilated, and you can see the tethering of both the septal and anterior leaflets in this 2D image. Now looking at color, you can see the apically displaced color jet starting here, lower in the ventricle that rises all the way to the right atrium, so we would consider this severe insufficiency. So when discussing this patient, we had her come down to the tertiary center here in Pittsburgh to deliver. She had severe insufficiency, cardiomegaly, IUGR. So it was delivered here in Pittsburgh. Since there was antegrade flow across the pulmonary valve and the TR systolic gradient was greater than 50% of gestational age at 33 millimeters of mercury, no prostaglandins were not needed for transport. So how did this patient do? She delivered, oxygen saturations were 96%. She was transferred to the Children's Hospital with severe tricuspid valve insufficiency. She was in the NICU for about 7 days and discharged home with moderate tricuspid valve insufficiency. She's currently followed in my clinic, and we are determining cone repair timing for her. So she's overall growing and doing well. Case 2, so this is a patient who was sent to us because of right-sided dilatation, and also father of the baby had transposition of the great arteries. So this patient was sent to us at 27 weeks. The tricuspid valve Z-score was 4, so enlarged, severe tricuspid valve insufficiency. And this patient had pulmonary atresia with no pulmonary valve insufficiency, retrograde flow across the ductus arteriosus. Cardiomegaly, severe dilation of the RA-RV, and had a lower peak tricuspid valve insufficiency gradient at 18. So this patient was again seen 4 weeks later, no real change in the pulmonary valve because that's what we're looking at. So still pulmonary atresia, no pulmonary valve insufficiency, and there's retrograde flow in the patent ductus arteriosus. Turning our attention to the tricuspid valve regurgitation gradient, again, it was still low at 17 and wasn't increasing with gestational age. So this patient was again seen prior to delivery at 37 weeks. No changes, pulmonary atresia, no pulmonary valve insufficiency, retrograde flow in the ductus arteriosus. And again, the peak tricuspid valve insufficiency gradient was 16, so on the lower side. So as you can see here, there's severe right atrial enlargement. There is septal and anterior tethering of both the valves. And you can see again, apically displaced tricuspid valve insufficiency that goes all the way to the right atrium, so severe tricuspid valve insufficiency. And then again, as we talked about, we're always looking at the pulmonary valve. So pulmonary valve atresia, we don't really see much leaflet movement. You don't see any pulmonary valve insufficiency, and you see retrograde flow in the ductus arteriosus. So for this patient, again, delivery at a tertiary center. For this patient, because there was pulmonary atresia and no pulmonary valve insufficiency and has been that way since about second trimester, and the tricuspid valve insufficiency gradient was low, the decision was to put the patient on prostaglandins for transport. Post-delivery, this patient had saturations less than 75%, so was intubated and transferred to the Children's Hospital of Pittsburgh. Just to show how tenuous these children are, this patient developed incessant ectopic atrial tachycardia within the first 12 hours of life and became hemodynamically unstable. They were placed on ECMO cannulation and then underwent a Starnes procedure at day 2 of life. Patient was monitored, and then by 6 months of life, they underwent a Starnes takedown and cone repair and monoclest pulmonary valve repair, and is currently at home. So the last 2 cases are the challenging ones that we're always wondering what to do. So this is another patient from the area who just came in because they had dilation of the right atrium, and came to our office at 26 weeks. The tricuspid valve Z-score was 2, moderate tricuspid valve insufficiency, a nice tricuspid valve gradient of 27 millimeters of mercury, and anterograde flow through the pulmonary valve. This patient came back 3 weeks later, and as we talked about, things can change, things can evolve during pregnancy. So just 3 weeks later, and there's now pulmonary atresia, and there's pulmonary valve insufficiency, there's retrograde flow through the ductus arteriosus, no evidence of hydrops. So once we see changes in changes to pulmonary atresia or pulmonary insufficiency, our MFM team starts doing biophysical profiles more often to monitor for growth and any signs of distress. Unfortunately, at around 34 weeks of gestation, the patient came in for a routine biophysical profile and was noted to have abdominal ascites and end diastolic umbilical flow in their umbilical arteries, as you can see here on the Doppler patterns. So repeat fetal echocardiogram showed worsening of the pulmonary valve insufficiency. The TR gradient was 32 millimeters of mercury at 34 weeks of life. So we were really hopeful that that the pulmonary valve may open. So this patient was admitted to the hospital. Mother was admitted over hospital for monitoring. Unfortunately, the fetus had multiple episodes of bradycardia, so was delivered the next day. Here you can see in their fetal echocardiogram, here's the right atrial enlargement. You can see how tethered the septal leaflet and especially the anterior leaflet, really displacing that functional annulus. So again, severe tricuspid valve insufficiency goes all the way up to the top of the right atrium. And again, looking at the pulmonary valve, so here's your pulmonary valve. You really don't see much movement. You can see here the retrograde flow through the patent ductus arteriosus, and here you can see the pulmonary valve insufficiency. So for this patient, due to concern of worsening circular shunt, the ascites, and the umbilical artery Dopplers, it was determined that she would be delivered the next day. Since the TR systolic gradient was 32 millimeters of mercury, and our hope was that the pulmonary valve would open, no prostaglandins were used for this patient. This patient delivered, and her oxygen saturations were 60 to 70%. She was placed on oxygen and transferred to the Children's Hospital of Pittsburgh, where a transthoracic echocardiogram showed that the pulmonary valve was opening with decreased velocity across. The left ventricle was underfilled, so she was supported with epinephrine and dopamine. And by day 3 of life, she had good velocity across her open pulmonary valve. She was transitioned to sildenafil for afterload reduction and was discharged home on room air 95% and is waiting for cone repair timing. And then our last case was a transfer from an outside hospital. This fetus had normal antegrade flow through the pulmonary valve. And then right before they came to us at 34 weeks, the study showed pulmonary atresia, no pulmonary valve insufficiency. So as we talked about, things change. At 36 weeks of gestation, there was still pulmonary atresia, but now there was moderate pulmonary valve insufficiency. And retrograde flow through the ductus arteriosus. The tricuspid valve systolic gradient was 28, so borderline, but still on the higher end. So as you can see here, there's a dilated right atrium and the significant tethering of the septal and anterior leaflets. You can see the severe tricuspid valve insufficiency going all the way to the top of the right atrium. and the pulmonary valve. So pulmonary valve here, not much leaflet movement, and you can see the pulmonary valve insufficiency and the retrograde flow through the ductus arteriosus. So delivered at a tertiary center, this patient actually after us seeing her in MFM, she was admitted overnight just for monitoring, noted to be in early labor. And since it was her 7th pregnancy, she underwent induction. Since the tricuspid valve systolic gradient was 28 and is borderline, the decision was no prostaglandins, and then we would tolerate SATs greater than 70%. Patient was delivered, SATs were 75 to 80%. He was placed on 100% nasal cannula and transferred to the cardiac ICU. Unfortunately, the infant saturations could not stay above 75% without the patent ductus arteriosus open, so underwent a PDA stent at day 10 of life to support their oxygen saturations 92% or greater, and just recently underwent a cone procedure. Thank you everyone for your time.
All right, thank you, Dr. Johnson. Next up, we have Dr. Justin Ye. He's going to discuss neonatal Epstein's care in the CICU. Dr. Ye joined us in 2018, and he's the Associate Professor of Critical Care Medicine and Pediatrics, as well as our Chief of the Cardiac ICU and Co-Director of the Heart Institute here at Children's Hospital of Pittsburgh.
Thank you, Dr. Villegas, for that kind introduction. I will be speaking to you today about neonatal Epstein's care in the cardiac ICU. I have no disclosures. Our objectives for today will be to take that excellent discussion that Dr. Johnson just had about fetal risk stratification and try to talk about how that informs how we prepare for these infants in the cardiac ICU. We'll talk about Epstein's postnatal physiology and its impact on our care in the cardiac ICU. Then we'll review what we've come up with here at Children's Hospital of Pittsburgh as our neonatal treatment algorithm for Epstein's anomaly. And finally, we'll segue that into a discussion of postoperative management. As has been discussed already, we know that Epstein's anomaly is a lesion with variable presentations, which is really secondary to variability in the underlying anatomic substrate. Neonatal presentation usually connotes more severe disease, yet there's still really a spectrum of patient presentations and outcomes, and that was clearly illustrated in Dr. Johnson's discussion. I'll take you back to that study that she alluded to by Freud et al. From 2015. This was a retrospective multi-center trial which looked at a compilation of fetal echoes to try to identify risk factors for perinatal mortality. If you remember from Dr. Johnson's discussion, they had reported a perinatal mortality of 45% in this patient population. Several factors came out in their multivariate analysis, which have already been discussed, but were in review. The gestational age of diagnosis less than 32 weeks, which essentially meant that the fetus's heart was quite enlarged and was picked up earlier during their fetal evaluation. Tricuspid valve annulus diameter Z-score was also noted to be significant in the multivariate analysis. The presence of pulmonary regurgitation was also noted to be a significant risk factor and clearly could be a potential harbinger of developing a circular shunt physiology. And then last, the presence of a pericardial effusion, which likely indicates the presence of right heart failure and could be a precursor to the development of high drops. Dr. Johnson did a nice job delineating how we establish a risk stratification system for evaluation of our fetuses with Epstein's anomaly. And if you'll remember, the essential criteria was determining whether or not there's antegrade pulmonary blood flow at all. So that was in the category 1. If present, those are typically less at-risk patients. Patients who don't have evidence of antegrade pulmonary blood flow in utero. We typically use a strategy of identifying whether or not there's the presence of associated pulmonary regurgitation, as well as assessing the ability of the right ventricle to develop an adequate systolic pressure head. Now, I don't have the excellent accent or the gravitas of Dr. Anderson, but I'll take you back to the anatomy, if only to leave that as an entree into discussion of the physiology of this lesion. As you'll remember, there's significant abnormalities in the tricuspid valve, which leave patients with a combination of regurgitation through that valve, as well as in more severe variants, obstruction to antegrade pulmonary blood flow. There's also typically the presence of an atrial septal defect with right to left shunting at the level of that lesion, which also connotes a degree of cyanosis. This is not untypical X-ray of a patient with Epstein's anomaly, and you can see that there's significant cardiomegaly with likely associated compression of the nearby lung structures. Infants, neonates with Epstein's anomaly will typically have a kind of triad of presentations, which include cyanosis, congestive heart failure, and abnormal cardiopulmonary interactions. One of the important things we do in the cardiac ICU, and an idea that we try to instill in our trainees' heads as they're trying to figure out how to manage these patients and all of our patients in the cardiac ICU, is it's important to not only understand the anatomy, but how does that anatomy inform the patient's physiology? So in our more severe anatomic variants of Epstein's, these involve severe tricuspid regurgitation, cardiac dilatation, and reduced or non-existent antegrade pulmonary blood flow. Progressive right heart dilatation leads to deleterious interventricular interactions and impairs cardiac output. I'll ask you to think back to those excellent images that Dr. Christopher had on the cardiac MRI, which showed dilated right heart structures that then led to a secondary shift in the ventricular septum. This impairs left ventricular filling and leads to decremental decline in left ventricular systemic output. Progressive cardiac enlargement also restricts lung inflation and leads to derangements in gas exchange. So we have patients with a combination of right heart failure, perhaps some degree of left ventricular dysfunction secondary to poor interventricular interactions, lung compression, and cyanosis. So what are the guiding principles that we use to lead our management in the cardiac ICU? Our first principle is to ensure that there's pulmonary blood flow. So if possible, we try to encourage antegrade pulmonary blood flow by reducing pulmonary vascular resistance. We support ventricular function, frequently the right ventricle, but that may also include left ventricular support. And we support gas exchange while recognizing the deleterious effects of positive pressure and RV mechanics. If you'll remember back to your physiology classes in medical school, you'll remember that positive pressure ventilation is salutary for reduction in LV afterload, but does increase RV afterload. This is an algorithm that is from one of the more recent papers from our Silva team. And I think it's helpful to kind of illustrate the general principles for how we approach our neonates with Epstein's anomaly. There will be a subset of patients that are more hemodynamically stable, and really, as Dr. Johnson was alluding to in her discussion, medical management is focused on minimizing pulmonary vascular resistance, encouraging antegrade pulmonary blood flow, and trying to put the patients in a setup where they can be medically managed and defer intervention until they reach an older age, at which we're most likely going to have a very successful cone repair. We also have a subset of patients that are much more complex to manage, which include either functional pulmonary atresia, anatomic pulmonary atresia, or the presence of a circular shunt. We'll go through the details of this management further in the later parts of this discussion. So oxygen and additional pulmonary vasodilator therapy in the form of nitric oxide as needed is used to encourage antegrade pulmonary blood flow. We make careful assessments of whether it's actually helpful to maintain patency of the ductus arteriosus. In some situations, clearly, where there is anatomic pulmonary atresia, maintenance of the ductus arteriosus is absolutely necessary to ensure adequate pulmonary blood flow. But in situations in which there is functional pulmonary atresia, allowing ductal closure to occur can allow the PA pressures to drop and encourage prograde flow through the pulmonary valve. Inotropy is added in as needed to support ventricular function, and frequently positive pressure ventilation, particularly in cases where patients have significant cardiomegaly and lung compression, is necessary to support gas exchange. A subpopulation of these patients is going to fall out and fail medical management. And typically this is secondary either to inadequate antegrade pulmonary blood flow and or ductal dependence. And a subset of these patients will also have decompensated congestive heart failure. This is a complicated secondary subgroup. So this can be ranging anywhere from patients who have very severe, in essence, cardiogenic shock in the setting of having a circular shunt, to patients who have struggled with right heart failure secondary to their severe TR, and for the most part can be medically managed but are not growing and have evidence of failure to thrive. No discussion of Epstein's would be comprehensive without discussing arrhythmias. Dr. Arora already had an excellent discussion of this. I only include touching on this topic to say that the presence of atrial arrhythmias, particularly in the higher risk subgroup of patients that already have tenuous circulations, can be very dangerous and can have devastating consequences. Dr. Johnson in her discussion alluded to a patient that we had who had significant atrial tachycardia and required emergent intervention with ECMO to stabilize that patient before further intervention. In our experience, we found the ventricular arrhythmias to be possible, but much more likely to be present in older patients. I'll take you back to that diagram. This is from a paper by Wald et al. That discussed management of patients with circular shunt physiology. The main take-home point from this patient population is that essentially blood flow is continuously, for the most part, recirculated through the pulmonary vascular bed, and there is significant systemic steal, which essentially leads to a low cardiac output state. In particular, you can see as you work your way through the diagram that there's left to right flow through the duct into the pulmonary vascular bed, then further retrograde flow through PR into the right ventricle. TR brings that flow back into the right atrium. Through a right to left shunt, it goes across the ASD out into the left ventricle, back out the aorta, but not primarily into the systemic circulation, and just goes through the duct back into the pulmonary vascular bed. You are quite limited from a medical standpoint in managing it. Your primary interventions would be to try to restrict ductal flow, either through discontinuation of prostaglandin or through more active means such as introduction of indomethacin. And there's clearly some papers which we haven't talked about in this discussion, which have raised the concept of trying to introduce the use of indomethacin during fetal life to try to restrict the duct and reduce the degree of pulmonary regurgitation. From a surgical intervention standpoint, interrupting that circular shunt can be done either through ductal ligation or in a more definitive way through MPA ligation to interrupt the flow of that circular shunt. ECMO is certainly an important accessory tool which may be necessary in this situation to support circulation pending surgical intervention. I'd now like to take a minute to review the current algorithm that we've come up with at Children's Hospital for our neonatal Epstein's patient. I'd like to extend a word of thanks to our the Silva team for sharing this slide with me so that I can then share it with you in this discussion. Let's first look on this side of the diagram. So in patients who have adequate antegrade pulmonary blood flow, our efforts are directed at not instituting prostaglandins and then following the patient clinically to see how they perform. So in patients that are able to be medically managed without evidence of significant right heart failure and demonstrate somatic growth, we would prefer in that group to continue the medical management strategy and then plan for a cone at the 2 to 5 year age range, essentially in toddler life. For patients who have significant right heart failure in the setting typically of severe tricuspid regurgitation, there are a variety of options available, and these will be discussed in the next talk, but could include ductal closure, cone, in selective cases, and/or Starnes. In patients who have inadequate forward flow in the form of pulmonary atresia, either functional or anatomic, there are additional pathways. So for patients with functional pulmonary atresia, meaning they have a pulmonary valve that could possibly open, and they have a pulmonary valve annulus, which seems reasonable in size, which for us would be a minimum of a -2, but greater than a -2 Z-score. We try to wean prostaglandins with the goal of seeing if we can encourage antegrade pulmonary blood flow. We would accept some degree of cyanosis. I wouldn't say no cyanosis, but some degree of cyanosis. Typically, if patients are able to maintain saturations in the 80s, we would consider that adequate and would be willing to continue medical management in that group, with the hope that they would then continue down the pathway towards deferring surgical intervention to a later age. For patients that have more significant cyanosis, their next step is really determined by the degree of both tricuspid regurgitation and the degree of cardiac dilatation as measured by their cardiothoracic ratio. So for patients with a CTR less than 0.8, those patients can typically be managed by adding in an additional source of pulmonary blood flow, either by means of a Blalock-Taussig shunt or by a ductal stent. For patients that have more severe TR and a significantly large cardiothoracic ratio, meaning greater than 0.85, these patients would then undergo a Starnes procedure. For patients with anatomic pulmonary atresia, they obviously require prostaglandins, and for intervention, they would undergo the same type of kind of intellectual exercise of assessing the degree of tricuspid regurgitation and the degree of cardiac dilation. In regards to postoperative management, obviously inotropes are important to support ventricular function. For patients that have a more biventricular type repair, it's important to have judicious use of volume expansion, with the concept being that you wouldn't want to acutely dilate the right ventricle and put all those nice fresh suture lines at risk. In addition, for patients with biventricular repair, pulmonary vasodilators and vent maneuvers to minimize pulmonary vascular resistance in an effort to reduce RV afterload are very important. Judicious use of sedation to minimize significant perturbations in pulmonary vascular resistance, as well as to reduce systemic afterload, can be very helpful. And of course, vigilant monitoring for arrhythmias and prompt management is important. I'll just take a quick second to talk briefly about a quality improvement exercise which has been pushed through the Pulmonary Critical Care Consortium. This was called the Cardiac Arrest Prevention Initiative. This is really a simple tool which was used to try to create a shared mental model and increase situational awareness for the ICU team. The concept being that twice a day, we would review patients that are particularly at high risk for potential decompensation and cardiac arrest. The bedside nurse, as well as the ICU team, the respiratory therapist managing that patient, and the charge nurse are all present for this discussion in the form of a huddle. We would discuss the potential means by which the patient could decompensate and/or suffer a cardiac arrest. We would go over the warning signs for how we would identify that that is to occur. We review preventive measures that can be helpful in reducing patient irritability. We have a quick assessment of all resuscitative equipment and make sure that it's close by at the bedside. We talk about vascular access, and then we review briefly whether or not the patient's an ECMO candidate and how that cannulation is to occur. Then we go through vital signs and we set actual goal parameters for those vital signs, as well as alarm limits for our nursing staff. This is not a tool that we use only for EBSTEIN'S, but is for our general cardiac ICU patient population. And this has been found to be quite salutary through the investigation of the PC4 network and has been successful in reducing cardiac arrest in our overall cardiac ICU population. In summary, the varying spectrum of presentations in physiology for neonatal EBSTEIN'S anomaly demand a tailored approach to management. Medical management is certainly possible in a subgroup of patients with mild to more moderate disease burden and can delay surgical intervention. Coordination with our skilled surgical partners is absolutely critical for the management of these patients with severe disease, and proactive surgical planning may help to optimize outcomes. Thank you very much for your attention, and these are my references. It is now my pleasure to introduce our next speaker, Dr. Luciana de Fonseca de Silva, who is a clinical assistant professor here at the University of Pittsburgh School of Medicine in the Department of Cardiothoracic Surgery. She is one of our absolutely excellent pediatric cardiothoracic surgeons here at Children's Hospital Pittsburgh. And her topic of discussion is going to be surgical treatment in neonatal EBSTEIN'S, what is new?
Thank you, Dr. Ye, for the introduction. I have no disclosures. I will talk about the surgical treatment of neonatal EBSTEIN'S. But first, I would like to highlight the contributions of University of Pittsburgh. In the 80s, Dr. Zuber-Buehler and Dr. Anderson, they studied anatomical specimens and described very well the distal attachment of the EBSTEIN'S anomaly. Earlier on in the 60s, Dr. Benson was doing surgeries using the Hunter and Lillehei technique. So EBSTEIN'S anomaly is not a new thing for UPMC. And some years ago, thank you, Dr. Victor Morell and Dr. Kreutzer for creating the Da Silva Center for EBSTEIN'S Anomaly in honor to Dr. Da Silva, that was the creator of the CON technique, with the goal to improve the treatment of EBSTEIN'S anomaly. And one of the challenges for us is to improve the treatment of neonatal EBSTEIN'S. As previously shown, if the diagnosis is made in the fetal life, the chance of survival is poor. So, and they have high risk if there is no antegrade pulmonary flow or depressed LV function. Pulmonary regurgitation is the most powerful hemodynamic indicator of risk, meaning that there is a circular shunt physiology. So innovative therapeutic approaches are needed to improve the survival. As the use of non-inflammatory, anti-inflammatory drugs in the fetal life, or early ductal closure in the circular shunt, and even innovative and prompt surgical management. The risk for mortality under the age of 3 months was already explained, and I will call attention for the tetradistal attachment of the anterior superior leaflet, the presence of pulmonary stenosis or atresia, the RV dysplasia, and the LV compressed by the right ventricle. This was well described earlier on. But the late sudden death can still occur in those who survive the fetal life and the newborn period. So we need to follow those patients, giving them the best treatment. The surgical results in this population is still not good. So in this study made by the Society of Thoracic Surgeons in 95 centers in US, among patients operated between 2010 to 2016, the overall operative mortality was 27.4%, no matter what kind of procedure was performed. So the STARNS procedure is one of the approaches that can be applied. It was created in 1991 by Dr. Starnes, and it's effective as an early palliative treatment in patients with heart failure. It's adequate for all anatomic types of EBSTEIN'S anomaly, and we do in the STARNS procedure the exclusion of the left ventricle with a patch with orifice in the middle to exclude the tricuspid valve and the right ventricle. So this immediately decompress the left ventricle. The midterm survival in his experience was 81% at 10 years by committing the patients to single ventricle pathway. So what we changed here at UPMC, Dr. Da Silva did a con after the STARNS procedure. So changing the univentricular heart to a biventricular heart. The con procedure itself in the neonatal period can be done in those patients with good right ventricular function and good leaflets. I mean, good focal attachment and not very rotated to the RVOT. Here is a result after 6 months and 36 months with the patient submitted the con procedure by Dr. Da Silva. But we need to remember that those patients are very small. You see the hand of the surgeon compared to the size of the heart. The leaflets are very fragile and we need to mobilize all the leaflets. So, and in this situation, the focal attachment would be easier to do it. But in this kind of presentation, the linear attachment or very displaced valve, it would not be a good chance to survive during the neonatal period. Our previous experience in Brazil with 5 newborns was presented in 2014, and we had favorable, good results in patients with favorable tricuspid valve anatomy and good right ventricular function. For other patients, we need to choose palliative procedures until the age is adequate for the con. So the radiographic follow-up in one of our patients showed a very good decompression of the ventricle and decreasing of the size of the ventricle, in this case, 17 days in the postoperative period. But again, in patients with good right ventricular function and good anatomy. In those patients with very displaced tricuspid valve, like this one here, Dr. Lanford demonstrated earlier on this case. This patient was submitted to a BT shunt in another institution. And he came to us later on with severe cyanosis and a poor response to exercise. We then, in the surgical procedure, what we found was a very displaced tricuspid valve. It was almost impossible to detach the leaflets from the ventricle. It was very, very muscularized, and we could see even the fat in the outside of the ventricle. It was a very tough case, but at the end, the result was very good, with a good left tricuspid valve function and a good RVOT flow. So this is one case. There was another case submitted to the stent in the PDA here. In patients with neonatal EBSTEIN, as Dr. Ye mentioned before, we have clinical treatment to offer, and in those very unstable, we need to offer more aggressive treatment. Like in this baby here, that in the first night of life need to go on ECMO through cervical cannulation. And then next day, Dr. Victor Morell performed the STARNS procedure. The kid then survived, and after 5 months, we were able to do the con repair, recovering that patient to a biventricular repair. We published this paper in 2020, and now we have 3 cases after starts doing the con. In that operation, we need to remove the patch that was closing the tricuspid valve. So underneath, we can see the leaflets of the tricuspid valve that in this case was displaced to the RVOT. And this is the final result with the con repair. Also, in those patients, there was pulmonary atresia, and then we need to do commissurotomy of the valve and enlargement of the anterior leaflet to be more adequate, to have more adequate forward flow. And here is one case with the newborn with Epstein anomaly, a very displaced valve after STARNS. And the advantage of the STARNS procedure is the decompression of the right ventricle. So at some point, we will have a good function that can be measured by the gradient, regurgitant gradient in the orifice, and by the quality of beating of the heart. And here, after the con and pulmonary valvoplasty, we can see a good forward flow and a good flow in the pulmonary valve. In circular shunt, as I said before, we can use non-steroidal anti-inflammatory drugs. This was a case done in Brazil. Dr. Lilian Lopes used anti-inflammatory drugs to do the ductal constriction. As we can see here in this curve, that kid presented with pleural effusion and ascites. So this was the reason for the medical treatment. And after, in the third 4 week of life, the baby was born weighing only 2 kilos. And then this patient was submitted to the STARNS procedure by Dr. Freire, and then later after, and the pulmonary artery closure. And then later after, Dr. Da Silva did the con procedure and pulmonary valvoplasty at 5 months of life with a very good result. So in our experience, at least here at the UPMC, all the roads lead to Rome. Oh, no, to the con, sorry. But Dr. Ye presented very well our fluxogram, how to treat those patients. Some of them, they need to do a BT shunt or a PDA stent. Some of them needs to be submitted to the STARNS procedure or PDA closure. And those with the circular shunt, the STARNS procedure plus pulmonary artery close. But at the end, everyone can be submitted to the con procedure, and sometimes we need to add the bidirectional gland if the RV function is not as good. So in our experience here at the Children's Hospital since 2016, we had 36 patients. 4 were submitted to the neonatal procedure, and 3 of them were submitted to the con repair after the STARNS. 1 of them is waiting for the repair. The neonatal con repair was done in 2 patients, and call attention that some of those newborns were very sick and 3 on ECMO before the con or the STARNS procedure. 1 con repair was needed in 1 neonatal con repair. And the con repair in adults or later on life, we have done in 30 patients and 3 after BT shunt. So in summary, the clinical and anatomical presentations will define the treatment in neonatal Ebstein's. The Da Silva con procedure in neonatal Ebstein can be used as the primary biventricular repair in a specific subset of cases after BT shunt or PDA stent after an initial neonatal STARNS procedure. For critical newborns with the Ebstein's anomaly, the staged approach with the STARS procedure followed by the cone procedure is favored over primary to ventricular repair. As I said before, this was an innovation of Dr. Silva done here at Pittsburgh, and with the cone after the STARS. And a prompt medical attention with ECMO and early intervention is advisable in critical neonatal Epstein, and this is very well done for our professional team. Thank you so much.
All right, thank you, everyone. Back to our discussion. So we'll start off with Dr. Ye. First question is, what is the management strategy in neonatal Epstein's with functional pulmonary atresia? I could pull up your slide if you'd like.
Sure. That's a good question. So with functional pulmonary atresia, the goal is to try to see if we can actually let the duct close, encourage antegrade pulmonary blood flow. We do that by trying to decrease PVR. So giving supplemental oxygen, in some cases, nitric oxide as well, and then supporting right ventricular function. A portion of that decision in determining how successful we're going to be in functional pulmonary atresia with achieving antegrade pulmonary blood flow is a couple things. So one is the morphology of the pulmonary valve annulus and the pulmonary valve itself. The second is how much functional right ventricle we have. And then the third is what kind of pressure head can the RV generate as measured by the tricuspid regurgitation.
The next question, I think the answer was alluded to by both Dr. Johnson and Dr. Fonseca, but would you consider treating the mother with ibuprofen to prevent circular shunt in utero and allow for more fetal growth? And what is the criteria for choosing those patients?
So for those patients, I think a lot of it depends on their gestational age and when we would consider endomethacin or ibuprofen therapy. And just, as you can see, some of the papers, the most recent paper published in 2021 sort of looked at their cohort, I think of 12 or 15 patients, their mean age was 30. So that they treated. So anywhere from 20 to 34. So I think it's really just the age of the patient and what else is going on for that patient to consider ibuprofen or endomethacin.
Yes, especially in those presenting with hydrops and pleural effusion, we should consider it, and we need to have those patients being born as mature as possible. So if the patient is not doing well intrauterus, we need to use it. And we need to be prepared for those patients to be born in a place where they can go to the surgery immediately, because they can need like the ligation of the PDA immediately after, or like in that case that I presented, the patient was in a very poor condition with 2 kilos, and then he needed to be treated with immediately going on cardiopulmonary bypass and doing the STARS procedure. So those patients, we need to have a very good multi-professional team working together to prevent the deaths.
Excellent, and that answer touched on the next question too, so we'll move on. So what is the optimal CVP after cone procedure?
Yeah, the optimal CVP is a normal CVP. So because what we expect after the cone, a normal function of the ventricle and a normal tricuspid valve. Of course, there are patients that we have some dysfunction. So in those patients, I go into the side of Dr. Ye, we need to decrease the pulmonary artery pressure and resistance with some drugs. Dr. Ye?
Yeah, I would say to supplement Dr. De Silva's discussion, I wouldn't truly use one number as a definition of how successful we're being in the postoperative period. There's typically fluctuations in the CVP. If we're seeing persistent elevated double-digit CVP, that's usually more concerning. We want to look at how the patient is doing clinically as a whole. So if there's other markers of good clinical cardiac output, any one individual CVP measurement becomes less concerning.
And then back to Dr. Johnson. So in the first case that you had presented, the echo to the person asking the question, they felt like it looked like tricuspid valve dysplasia, and the annulus appeared to be closer to its anatomic place. They were just like a comment, that's all.
Yeah, I think when the patient delivered, sometimes in fetal, you see a more posterior angle. So therefore it looks like tricuspid dysplasia. The same goes for the patient in the third case. On fetal, you saw more of the septal and inferior leaflets, so it did look like tricuspid dysplasia. This is the constant battle in our department in the echo lab, deciding is it tricuspid dysplasia or EBSTEIN'S. So I think sometimes fetally it looks more like tricuspid dysplasia, but then when you see it as a transthoracic, you see more of that anterior leaflet. So yes, I could see the first case being a discussion in our lab, is this tricuspid dysplasia or EBSTEIN'S?
All right, and that closes our discussion.
Thank you.
All right, our next family video is the Jocelyn and Megan Troglin family. And I first met Jocelyn and Megan when I was pre-opping Jocelyn for her cone procedure. And mom mentioned to me that they would be back in 6 months for her to have her cone procedure. So this is a little video that outlines their journey as a mom and daughter having their cone here in Pittsburgh.
Dr. De Silva was definitely down to earth and definitely made it a lot easier to prepare for the surgery. You know, we had so many questions and he was able to answer all of them, and he felt confident that the surgeries would go well. I will never forget walking down the hallway carrying Jocelyn to lay her down on the operating table. Me and the nurses started singing Girl on Fire to her, which was her favorite song, as the anesthesia was administered and her eyes rolled into the back of her head. It was a very scary 3 hours waiting in the waiting room for the nurses to come and tell us all of the updates, not knowing if she was going to survive. You know, just praying a lot, being with my family and hoping everything went smoothly. When Dr. De Silva walked through the double doors to the waiting room after her surgery, I couldn't breathe. It was such a surreal moment, you know, just waiting. When he came up to me, he had the biggest smile on his face. He told me that everything went perfectly, that she's a fighter, and that her heart was stabilized. The cone procedure took, and she was doing okay. I will never, ever forget that moment. 3 days after Jocelyn's surgery, she actually did a cartwheel after she was taken off all of her IVs in her room. She was so excited we had to calm her down so she didn't hurt herself. 3 months later, I followed in Jocelyn's footsteps to have my surgery done. After going through the experience with Jocelyn and Dr. De Silva, I was confident that everything was going to go smoothly. Recovery was a little bit more difficult than Jocelyn's. I think, you know, her being younger, everything was a little bit easier for her, and kids bounce right back. It was a little bit of a progress for me, but after cardiac rehab and just getting to fully embrace my heart, I was able to drop a lot of weight, you know, walk down a hallway without being out of breath, things I had never done before. I will forever be indebted to the team at UPMC, to Glenda for helping us along the way, to the nurses who took care of us, and to Dr. De Silva for giving us a new lease on life.
Hi, I'm Jocelyn and I'm 5 years old, and I love unicorns, and also I love my mom.
What are some things you like to do?
Well, I like to paint, and I also like to draw.
And what did Dr. De Silva do for you?
He did heart surgery.
And what did me and you have in common?
Epstein's Anomaly.
That's right. Are you happy?
Yeah.
All right, we're down to our last presenter before we have a final discussion with Jose Pedro. This will be Rüdiger Lang, who's the director of the Clinic for Cardiac and Vascular Surgery at the German Heart Institute in Munich, Germany. And I know that Jose Pedro and Rüdiger are good friends, and they collaborated throughout the years. And I know that in Munich, where he works, it has a long history in the management of Epstein's anomaly, and they're really interested in the surgical treatment of it. And we're looking forward to his talk on the outcomes of the cone procedure. Thank you.
Dear colleagues, ladies and gentlemen, thank you for the invitation and for the privilege to present our De Silva cone procedure data from the German Heart Center in Munich at this wonderful meeting. In the last 40 years, there have been different surgeries for Epstein malformation at the German Heart Center Munich. Altogether, up to 2016, we had 195 cases, and 88% of those cases received a repair. There were different repair techniques like the Hardyplasty, monocusp valve, other repair techniques, and only recently the cone procedure. We even developed our own technique, the Sebening stitch. Professor Sebening, my predecessor at the German Heart Center, developed this technique in the 1970s, and it was basically a technique to create a monocusp valve out of the Epstein malformation by pulling the anterior leaflet towards the native valve ring. And this is shown in this historical video. Here you see the posterior leaflet, multiple tethering. There's a gap in the posterior leaflet, a gap between the anterior and the posterior leaflet, which is closed here, another perforation in the posterior leaflet. So all the gaps and perforations were closed to create one single plane as the new monocusp leaflet. And then after this plane had been created, the papillary muscle of the anterior leaflet was identified, a plagiatus suture was attached, and the monocusp leaflet was pulled down to the septum of the right ventricle. And then plagiated divigakineplasty was used to reduce the ring. Now, as you all know, the results of all these techniques were never sufficient. Here we looked at the 25 years of different repair techniques, excluding the cone technique, and it shows very nicely that at 25 years, 73% of the patients had developed more than moderate TI, 51% even more than severe TI, and the rate of reoperations after 25 years with different repair techniques was 43%. So we had the great privilege to be invited by Professor De Silva and his wonderful wife Luciana Fonseca to Sao Paulo in September 2009 I was accompanied by my dear colleague, Professor Christian Schreiber, who unfortunately deceased, and we both wanted to learn this technique, and we received the first steps in Sao Paulo. After this, Professor da Silva and Luciana came to Germany several times, and we did the first operations together and developed the technique for our center. It took me some time to understand why the cone procedure was the preferred technique for the Epstein malformation. If you look at this three-dimensional model of the right ventricle, you see this inward displacement of the posterior leaflet and the septal leaflet deep down into the right ventricle towards the apex of the right ventricle. So if you want to repair this valve with all three leaflets, anterior, posterior and septal, you cannot do it in a plain fashion like the other valves, but you have to create something that goes into the ventricle like a cone. This is an example of surgery at the German Heart Center of a severe Epstein disease. As you see here, the posterior leaflet, multiple tethering, the displacement of the annulus into the ventricle, the attached septal leaflet, and here the anterior leaflet, which is usually free for repair. So we developed our own procedure in so far that we follow always the same steps. We cut at the anterior leaflet first, then it's followed by a dissection of the septal leaflet, and then dissection of the posterior leaflet all the way down as far as possible into the right ventricle. After this, here you see leaflet, septal, and posterior and anterior. And after this, we do the ugliest part of the procedure. I call it the ugliest part because you always, during this plication procedure, you're always afraid that you might hit the right coronary artery. Fortunately, it hasn't happened to us yet, but you're always concerned that it might happen. And here, the creation of the cone starts. The septal leaflet and the anterior leaflet are connected by a running suture, and what is extremely important for this operation is that all the leaflets are without any tension. If there is only a little bit of tension, one detachment that hasn't been loosened, then the cone cannot work. And here you see then the attachment of the leaflets to the valve ring. The valve ring has been longitudinally plicated before. Now there are some more single plications on the ring to make it fit for the leaflets, and then the leaflets are attached to the valve ring. And you see the locked continuous sutures, and here it's the water test and shows the competent valve, which is also shown on the beating heart on echocardiography. You see the cone very nicely compressing and without any insufficiency. Now we looked at several aspects of the cone procedure in our experience. We looked at the cone, how it compared to conventional repair for Epstein anomaly. As you saw already before, here the incidence of more than moderate TR for other repair techniques compared to the cone operation. Of course, we have to admit that the median follow-up for the cone procedure in this publication was only 3.7 years. The longest was about 7.5 to 8 years. But still it shows you that at least in the midterm, you have excellent results and almost no residual tricuspid regurgitation with the cone procedure compared to other repair techniques, and the comparison was highly significant. And also for the incidence of reoperation, you see there was no cone procedure which had to have a reoperation, as opposed to a lot of reoperations with other repair technique, again highly significant. So the functional results with the cone procedure, at least in the midterm, are excellent. We also looked at the preoperative predictability of right ventricular failure following surgery for Epstein anomaly. The question that we wanted to answer is there a patient subpopulation with Epstein disease who would benefit more from a quick and straightforward tricuspid valve replacement rather than a cone procedure? So we tried to develop risk criteria which had not been evaluated for Epstein disease and also not for the cone procedure. And we said age more than 40, right ventricular volume index, anti-systolic volume index more than 200 milliliters per square meters, and right ventricular ejection fraction less than 40%. So we looked at 68 patients, 40 patients with at least one risk factor, 24 patients with age more than 40 years, 16 patients with decreased right ventricular ejection fraction of less than 40, and 18 patients with right ventricular end-diastolic volume index of more than 200. And this shows you the distribution of those 40 patients in the different risk groups. And in the center you see 3 patients who had all 3 risk factors. And if you look at mortality, all 3 patients who had all 3 risk factors died. So age, decreased right ventricular function, and a large dilated right ventricle has to be considered and are considered to be preoperative warning signs for complicated postoperative course. So before planning to do a cone procedure, these risk factors should be evaluated, and eventually the procedure should be switched to a quick valve replacement. And then we also looked at cone repair for Epstein's anomaly and its effect on right ventricular size and function. This was an MRI study we did early after our initial experience. And you see here very nicely on the left panel, you see the huge right ventricle with a big atrialized portion without any contractions, and after the cone operation on the right panel, you see it appears almost like a normal physiology after the operation. Here again, you see the small contracting part before the Epstein repair and the huge atrialized portion of the right ventricle, and on the right side, almost physiologic appearance of the right ventricle. So of course, we found that the right ventricular ejection fraction decreased after cone and after the plication. Now why? Because the regurgitant volume was not there anymore, because the valve was competent, and also because the ventricle had become smaller. But the good news was that not only the right ventricle becomes smaller, but that it also provides more forward flow. On the left panel you see the end-diastolic volume of the right ventricle, which decreased considerably and significantly. And on the right panel you see the integrate net stroke volume index, which increased in almost all patients, highly significant at 0.035. So what have we learned from our experience of the cone procedure? It is a reliable repair technique with excellent midterm results. Not every patient is eligible for a cone repair. Multiple risk factors have to be considered. Early MRT studies show an improvement of right ventricular function. However, the quality of life improvement and the survival benefit, they both are yet to be shown for this procedure. So to gain more experience and to gather patients from all over Germany and also from Europe, we founded the Epstein Zentrum at the German Heart Center 3 years ago. And this was a big success because we now have a sufficient caseload for the whole team to be always in practice. And with this, I end my presentation, but not without to thank Luciana Fonseca and Pedro da Silva for their incredible support. Here you see the two with me during one of the visits in Munich. We have our little kids on our shoulders. They are now much bigger, but the friendship between those two excellent surgeons and the German Heart Center will always stay there. So thank you both for all your support and for everything you have done for the German Heart Center. And I thank you all for your attention and for the privilege to present.
Well, that was a wonderful presentation and obviously describing the benefits of the cone and there are obviously physiological changes associated with the cone that lead to a better outcome and they're measurable. So it's a terrific procedure. We're down to the end of the symposium, guys, and I just wanted to take a few minutes. I will just say for me personally, what learning the cone procedure from Jose and Luciana, the biggest challenge for me was to realize that you have to take down all those adhesions all the way down to the apex of the heart, and you're gonna just leave a few of them. That seemed a little scary for me at the beginning. And after having the master next to me telling me, go ahead, do it, realized that this is really the only way it works. And I think Dr. Lang made a good point. There can't be any attachments left for the cone to work well. And this is something that I think we all, there's clearly a learning curve to it, but it's quite doable. And Jose, do you want to comment on maybe, I'm sure there's many people in the audience who've never done it, or and what would you suggest would be the key components of for a surgeon out there to do this procedure?
I think you just delineated. First, you have, of course, to analyze the anatomy and to know what you have to do, because depending on anatomy, you have to do different maneuvers. But at the end, you have to mobilize all the leaflets and extensively. And then sometimes you have to rotate tissues to get the height of the all leaflet, all the cone areas. And sometimes maybe you need to add some tissue from outside. This has been rare in my experience, but I think can be very helpful if you are at the beginning, you don't have much experience doing it. So basically it's that, because it's not mobile. For example, if you leave something attached to the anterior wall and to the anterior leaflet that is not deep enough, that's not near the apex, then when you fill up the right ventricle, it's kind of pull the leaflet laterally. And this creates a great tension in the suture of the cone and it can rupture. And this happened to me. I have to take the patient immediately to the OR. And that was the cause. I didn't take down the leaflet sufficiently to do the cone.
You know, another sort of a aha moment that I had in the operating room with you was when we were doing this cone on a patient, and the septal leaflet was just a little sliver of tissue that was very apically displaced. And I assumed that there was nothing to do with it. We're just gonna let it sit there and there's nothing to do with it. And you taught me, you said, dissect it, and we dissected the leaflet. There was no way we can bring it up, you know? So we start from the top and mobilize it down. And then we just utilize the septal leaflet, whatever was there, as a papillary muscle. So when we rotated the posterior leaflet, we ended up attaching the posterior leaflet at the apex to the septal leaflet, which basically helped anchor that posterior leaflet to the heart. And that septal leaflet just became a papillary muscle or an attachment for the cone to work. So again, there are just many little intricacies to this procedure that as you do the operation, you kind of learn. But obviously, you know, I sit here and now for those of us who do it, it's a very simple, you know, you go like, okay, so which way I didn't think of this procedure, you know, because it makes sense. As a surgeon, it makes a lot of sense why the cone works and how it works. And once you do it, you realize, well, this makes a lot of sense. And I certainly want to congratulate Jose and Luciana for all the work they've done with this procedure and, you know, to help manage the Epstein's anomaly, which in my eyes was sort of a horrific problem to have as a patient. And now I can say, you know, it's something that we can solve. So it's really been transformational, what Jose came up with, and I certainly want to congratulate you. And I want to give you a couple minutes to say a few things, whatever you might want to tell the public and all the attendees.
Okay, first of all, I have to thank you, Victor Morell, Jacques Kreutzer, and our group of surgeons, cardiac surgeons, like Melita, Luciana, Melita Viegas, Luciana Fonseca, and then Mario, that was not here, Mario Castro Medina, that has been working while we are here, and he is taking good care of our patient, also did save some patients that have the anomaly. So all the team involved. And also for putting together this meeting, I want to thank to Erin, Colvin, and Kate Scollon that were essential to make it work perfectly. And so at the end, I would like to thank our team of the Heart Institute Children's Hospital Pittsburgh, especially those who presented today. I want also to thank the speakers and like I said, and especially to the participation of Dr. Robert Anderson and Rudiger Lang. Dr. Anderson, everybody knows his work in anatomy and embryology of the heart with innovative ideas and concepts. Dr. Lang, he did his presentation, he showed the important work they have done with the Epstein anomaly, and he's an important team in Europe. And also I want to express my gratitude and honor to join the UPMC, an institution that supports innovative initiatives based on science, education, and also in technology, and also without losing the focus of a patient-centered medicine that have helped so many patients with many diseases and also help the family of those patients. So Thank you.
Well, it's been a real pleasure, and I hope that this proved to be educational for the participants. I have to say we certainly enjoyed this, and we're already planning on our next, it'll probably be about 6 months down the road, and likely it's going to be related to complex transpositions. So I hope that those in the audience will join in again in the future. We'll let you guys know when the webinar will occur. Again, I want to thank everybody, Angie, Katie, thanks for your support and making this happen. And certainly we want to say thanks to James Ferris, who's made the AV segment of this meeting work for all of us. Without him, this could not happen, certainly. And I hope you guys have a great weekend, and hopefully we'll see you in about 6 months. Take care.